complications of fracture. Okay, now, there are lots of complications which occurs in fracture, so we should classify them first and then, okay, then explain them one after other. You see here, the complications inevitably occur in a proportion of fracture. Not in all fracture the complication occur, but in majority of them, or in a proportion of the fracture, the complication will occur inevitably, means we cannot even avoid them. Okay, they would occur. This is the meaning. So that's what this topic is all about. With early diagnosis and treatment, the disability caused by these complications can be greatly reduced. Okay, so in this topic, we first list what are the complications of fracture, then we talk, a bit in detail about each of them. We talked about how to diagnose them, what are the important feature of them, and then how to treat them. Now let's classify. Complication of fracture can be classified into 3 broad groups depending upon the time of occurrence after the fracture, and these are as follows. Have a look there. So they are immediate complication, okay, early complications, and late complications. So immediate, early, and late. The immediate complication, they occur at the time of the fracture. Early, occurring in the initial few days after the fracture, and late, occurring a long time after the fracture. So let's list them first and then move further. Now see here, okay, all of you please focus on this screen. These are the immediate complication. Now regarding the systemic complication which occurs immediately, hypovolemic shock is one of the most important. Hypovolemic shock. So we'll talk about it. Every student know it already, what is the meaning, but still, a lot of important concepts are there. Regarding the local immediate complication, injury to the major blood vessel, injury to muscle and tendon, injury to the joint, and injury to the viscera. There are also some immediate complication, and these are important complication also. I want to give you some important relation or correlation or examples immediately. In case of fracture of humerus, which is known as supracondylar fracture of the humerus, means lower end of the humerus fracture, there is high chance of injury to the brachial artery. Brachial artery. If brachial artery is damaged or injured, okay, we may have ischemia on our forearm and the hand area, and this is a big problem. Injury to the muscles and tendons, joints, and viscera are some other. Now viscera. Now, those viscera can be damaged very easily in pelvic fracture, even rib fracture. We can damage our lung in rib fracture. Okay, remember skull fracture. If there is a depressed fracture of the skull, then brain can be damaged. So these are some good examples here. Now another is early complication, again systemic and local. Now regarding the systemic early complication, hypovolemic shock again, ARDS. I'm sure everybody know the full form of ARDS. What's that?
Acute respiratory distress syndrome.
Very good. Okay, every 100% of the student know this, and you should know this actually. You can either say acute respiratory distress syndrome or adult respiratory distress syndrome. Both are same. Acute respiratory distress syndrome or adult respiratory distress syndrome. These days we are facing the pandemic of COVID-19, okay, which is caused by SARS-CoV-2 virus. Now one of the most important cause of death in this COVID-19 disease is ARDS. Because of ARDS, people are dying. So we are talking about this, how in fracture this ARDS occur. Another is fat embolism syndrome. Okay, fat embolism, the name itself suggests there is presence of fat globules in the blood. Okay, and this is affecting important organ. The two important organs are lung and the brain. Lung is most important one. Another early complication is deep vein thrombosis and pulmonary embolism, DVT. Another is aseptic traumatic fever. This is not very important one. Another is septicemia, which is very common in open fracture or compound fracture because of its high chance of infection. And another is called cross syndrome. Okay, cross syndrome. We'll talk about this. This is important concept. Now, in a local type of early complication, infection and compartment syndrome may occur. Infection is the local one. If the same infection goes systemic, we call it septicemia. But in the beginning, it is always local. And compartment syndrome occur in a tight compartments like in the forearm, okay, and in the leg area, even in the thigh area, compartments are there. But this compartment syndrome more commonly occurs in the leg area and in the forearm area. So those compartments have very increased pressure, and because of those pressure, the blood flow would be compromised. This is called compartment syndrome. Now have a look at those late complications. The late complications can be imperfect union of the fracture. The fracture has not healed or united properly, and there may be delayed union. Delayed union means it is taking longer time than usual. Non-union, it has not united at all. There is failure of fracture healing. Non-union. Malunion, it has healed or it has united, but in a wrong way, okay, in an abnormal way. That is malunion. And cross union is a term which we mainly use for, okay, leg area and the forearm area again, because there are two bones present there. In lower leg, or leg I should say, tibia and fibula are there, okay, as a long bone. And in the forearm, radius and ulna. Now what happens sometimes, the ulna, fuses with radius, and radius fuses with ulna. Or tibia fuses with fibula, and fibula fuses with tibia. This is called cross union. This is very abnormal, and this is the imperfect union. Now other late complications can be a vascular necrosis of the bone, very important one. We'll talk about this, okay. Shortening of the bone, stiffness of the joint. In that affected area, the joint will become stiff, probably because of the prolonged immobilization or not using that proper joint. Sudex dystrophy, also known as reflex sympathetic dystrophy, or causalgia. If you remember, we talked about this in our first or second classes in orthopedics. Okay, Sudex dystrophy. Another term is reflex sympathetic dystrophy or causalgia, probably because of damage to the sympathetic nerves there. Okay, osteomyelitis is an infection of the bone. Ischemic contracture of the muscle because of the loss of blood supply to some of the muscles in that area. One of the very good example of this particular condition is known as Volkmann ischemic contracture. So we'll talk about that later, okay? Don't worry, this is just a listing. Let me write that term for you. Volkmann ischemic contracture. Now this Volkmann ischemic contracture, ischemic contracture occurs, okay, if a brachial artery is damaged by the fracture of the humerus. So of course student can say now this is the ischemic contracture of forearm muscles, forearm muscle, especially the flexor compartment group. Myositis ossificans is one of the important late complications of the fracture, where there is formation of bone in the joint area or around the joint area. Okay, so myositis ossificans. And osteoarthritis is degenerative disease of the joint. Degenerative disease of the joint, which is very common in fracture, okay, neck of the femur. Fracture neck of the femur, because the head of the femur is ischemic, and if we do not remove that head of the femur in time, which is completely dead, okay, now osteoarthritis is very common feature to occur in that common condition. So these are the complications of fractures. Very important question in any type of exam. Now let's move on. Let's talk one after other of these important complications. Okay, we cannot talk all of them. It takes a long time, and they are not very important also. But we choose the important complication and discuss. Now, what is hypovolemic shock? Okay, and what are the importance of hypovolemic shock in fracture? Let's talk about it. Hypovolemic shock, also known as hemorrhagic shock, is the commonest cause of death following fractures of major bone such as pelvis and femur. So you can clearly know the importance of this now. Commonest cause of death following the fracture of major bone like pelvis and femur. Now regarding the cause, okay, the cause is external hemorrhage or internal hemorrhage from the fracture site. This is the cause of hypovolemic shock. Now, external hemorrhage occur from a compound fracture. Every student know that. We have been talking about this in our 3 or 4 different classes. Compound fracture is the open fracture, so there is a high chance of external hemorrhage from there. At the same time, there may be associated injury to the major vessels of the limb. The vessel may be torn or may be ruptured, okay, by the sharp edge of the fracture bone. If that happens, then we continuously lose the blood from there, and it can easily lead to hypovolemic shock. Now, another important point is the internal hemorrhage. Now, this internal hemorrhage is more difficult to diagnose than the external hemorrhage because we don't see any external bleeding. Okay, we do not see, and this is very common to occur in the body cavities like chest or abdomen. Now, let me give you different examples here. In pelvic fracture, usually the blood doesn't come outside. The bleeding occurs in the pelvic cavity, which is a part of abdominal cavity. It's a very good example there. And another is a chest. In a bad type of rib fracture, in a sternum fracture, okay, then what will happen now? The bleeding may occur in the chest cavity or thoracic cavity. Now, one question I like to ask you: how to diagnose this internal hemorrhage? How to diagnose? Yes.
You have to ultrasound.
Sir, we can check the pulse. We can check the pulse. We can vital signs.
Very good. So see there, different students, okay, because all of you are speaking at the same time, so your names are not very clear on the screen, but still I can see a few of the names there. Very good answer. Now listen carefully. There are so many students, okay, so all of them are listening. I hope the 65 students right now on the screen, okay, if they are listening, so please focus here. This is important question by any teacher. Now regarding the internal hemorrhage, we cannot see the direct sign there, but we see the indirect sign, like we check the vitals. And regarding the vital, there is always tachycardia if a serious type of bleeding is occurring, tachycardia. And the strength of the pulse is low. It is called low volume pulse, okay, also known as weak and thready pulse. Weak and thready pulse is a hallmark of hypovolemia. Number 2, if a bleeding is very severe, then blood pressure also falls. But please do not rely on falling blood pressure only. Blood pressure falls only in a very late or serious situation. In the early situation, blood pressure doesn't fall. It is still within normal limit. Third one, examine capillary refill time. It will be prolonged in case of hypovolemia. Fourth, palpate the peripheral part of the body. They are cold and clammy. Cold and clammy. They're sweaty and they are cold. Okay. Look at the forehead. The patient may be sweating a bit. These all are very, very important point, and that's what they are pointing towards some type of blood loss, and in this case it is occurring in the body cavity. Now if it is occurring in the abdomen, okay, you can quickly go for ultrasound and see whether some fluid is collected inside the abdomen or not. Same test you can do in chest also. Maybe they occur in the pleural cavity, who knows. And pleural cavity collection is very easy to diagnose by ultrasound. You can even go for chest x-ray in case of chest. Okay, so see there, so this is the way you can easily diagnose internal hemorrhage. So high index of suspicion is necessary. Now let's move on. Significant blood loss may occur in fracture of the major bone like the pelvis. Around 1500 to 2000 ml of the blood can be easily lost, and in femur fracture around 1000 to 1500 ml, that is 1 liter to 1.5 liter, and in pelvic fracture about 1.5 liter to 2 liters of the blood. So easily the patient can develop hypovolemic shock in this situation. Now even more important point as a doctor, okay, how to manage these cases. Now remember one important point, though the patient has come to the hospital with fracture, I do not pay my attention to the fracture treatment right now, because the patient has developed shock already, and shock treatment is very, very important to save the life of the patient. I can manage that fracture later on. So many students, they probably spend a lot of time in the fracture management and forget completely about measuring the blood pressure and treatment of the shock, and they lose the patient. So this is not the way. We should always follow this particular way: A, B and C: airway, breathing, circulation. Let's hope airway is fine here. Let's hope breathing is also good. And C is for circulation. The circulation means maintenance of the blood pressure, maintenance of the blood volume. Now this is important. So put in at least 2 large bore intravenous cannula. Okay, number 16 or number 14 would be ideal, because they are large bore intravenous cannula on both limbs. 2000 ml of the crystalloid should be infused rapidly, followed by colloid and blood. This is the same standard way by which we treat every type of hypovolemic shock. There's nothing different here. In adult, you give 2000 ml of fluid very fast. Okay. In children, we use the formula 20 ml per kilo. 20 ml per kilo very fast. And we can repeat this up to 3 times in case of children. But in adult, okay, you can go like that, but you don't need to calculate in adult, push 2000 ml. Now how many bottles 2000 ml means? How many bottles?
5.
Remember, one bottle is 500 ml. Okay, one bottle of IV fluid is usually 500 ml. So see there, I'm telling you a little bit of practical information here. Give four bottles of the IV fluid very fast. That's it. And if you do that, probably the patient's blood volume will come up, okay, and blood pressure also come up. If it doesn't, then you go for colloid. Hemaxil is one of the example, and also the blood. Another important point is localize the site of bleeding, whether it is in the chest or in the abdomen, and we need to stop it. We need to tie it or coagulate it. Needle aspiration from the chest and diagnostic peritoneal lavage provide quick information. This is just the diagnostic way, and if possible, a plain X-ray chest and X-ray abdomen may be done or even ultrasound can be done. So all of this we have already explained. Nice. So let's continue. We are talking about the management of hemorrhagic or hypovolemic shock, which occurs in a case of fracture. Now, these are the major fracture, usually fractures of the major bone, like pelvic fracture or femur fracture. And there are two types of way by which hypovolemic shock occurs. One is external bleeding, mainly by the compound fracture, and another is internal bleeding, which we cannot see from outside. Now, regarding the management, we already talked before the break. First of all, we should put two large bore IV cannula, either 14 or 16 gauge, on either side of the body, maybe in the both upper limb, especially in the elbow area. Okay, we use the cubital vein there to cannulate. Then we give crystalloid. Around 2 liters of the fluid should be given very fast, and after that we'll examine the patient again. What is the blood pressure, what is the pulse rate, everything, and we judge whether the patient needs colloid or not. Okay, this is the way. Now some further management. A chest tube for chest bleeding, laparotomy for abdominal bleeding may be required. Now chest bleeding means this is called hemothorax, because the blood collection is in the pleural cavity. So we need to drain that blood with the help of chest tube. Laparotomy is the opening of peritoneal cavity. Now this is definitely has to be done in abdominal bleeding, because we need to find out the bleeder, which blood vessels is ruptured there, okay, which bone is fractured there, from where the bleeding is coming, and then we need to go for the appropriate treatment. Now, excessive blood loss from fractured bone may be prevented by avoiding moving the patient from one couch to the other. Now already the bone is fractured, and from that fractured site the bleeding is continuing, so avoid moving the patient. This is what a very important step in the management. For fracture of the pelvis, you stabilize, okay, the pelvis with an external fixator, so it will help in reducing the hemorrhage. And then in advanced trauma center, some sort of emergency angiography and embolization of the bleeding vessel is performed to control the bleeding from deeper vessels. These are advanced technique to decrease the hemorrhage. Angiography is done to know which vessel is bleeding, and embolization is done to stop the bleeding from that particular blood vessel. Okay, this is advanced type of therapy, but before that you don't move the patient from couch to couch. Okay, temporarily stabilize the fracture site, okay, and treat for the hypovolemia, and that would save the life of the patient. Let's move on. Now another type of complication which may occur immediately or quite early is ARDS. It takes a bit of time, actually, a bit of early type of complication, ARDS. Now it can be a sequelae of trauma with subsequent shock. Now what happens is, any case of major trauma of the bone or multiple fracture, okay, or multiple fracture of bones in our body is associated with ARDS. On top of that, if that fracture is so severe that it leads to hypovolemic shock, that hypovolemic shock will further aggravate ARDS. So remember this. The exact mechanism by how ARDS occur is not known, but it is hypothesized that it is due to release of high amount of cytokine, okay, high amount of cytokine or inflammatory mediator, and these cytokine cause disruption of the microvasculature of the pulmonary circulation. The microvasculature means pulmonary capillaries, they are disrupted. As a result of this, there is leakage of the protein rich fluid inside the alveoli, and that is known as ARDS. So in another term, ARDS is also known as non-cardiogenic pulmonary edema. So let me write that term for you so that you will understand it very easily. Non-cardiogenic, okay, pulmonary edema. See here. So this edema, okay, which occurs inside the lung or the fluid which is collected inside the alveoli, is not because of the heart condition. That's why non-cardiogenic, and it is mainly the exudative fluid. This is exudative fluid. The exudative fluid. It's a slightly protein-rich fluid than the other. Let's move on. The onset is usually 24 hours after the injury, so it is considered a case of early type of complication. The patient develops tachypnea and labored breathing. Tachypnea is faster rate of respiration, and labored breathing means difficulty to breathe. Now, how to diagnose? There are two important ways. One is do X-ray chest. That X-ray chest will show diffuse pulmonary infiltration. Diffuse pulmonary infiltration. In some of the cases, in very serious cases, I mean, the lungs would be white, okay, white out lung on both sides. And if we take ABG, the arterial PO2 usually falls to less than 50. This is severe hypoxemia. So these are some of the important points regarding ARDS. Okay, let's move on. Now, how to manage the case? Now, see here, 100% oxygen and assisted ventilation is necessary for the management. So this oxygen should be 100%, there's no doubt about it, and we give this oxygen under pressure. We give this oxygen with some force that is done by mechanical or assisted ventilation. See here, this is a very, very important, way of treatment. Without mechanical or assisted ventilation, this patient is going to die. Now, I again want to correlate this concept with the COVID-19 treatment which is going on all over the world these days. For the COVID-19 patient also who develop ARDS without ventilator therapy, they are going to die. Okay, the same ARDS can be developed in major bone fracture and multiple bone fracture as well. So similar type of therapy. So it takes from 7 to 10 days for the chest to clear and the patients return to normal. If not detected early, the patient will deteriorate rapidly and they die from cardiorespiratory failure. So this is a very serious condition, but we don't need to panic here, okay? The diagnosis should be done in time, and after we diagnose, the treatments is available, that is mechanical ventilation with 100% oxygen, and treat the condition which is causing it. In this case, okay, treat the fracture along with it. Now, another important condition which is there as a complication of the fracture is fat embolism syndrome. Fat embolism syndrome. This is very interesting type of complication. Now, this is one of the most serious complication to occur, and in this condition, there is occlusion of small vessels by fat globules. Okay, the small droplets of the fat or globules of the fat are blocking the capillaries, especially in the lung. Lung is the most important organ which is involved here. Now, regarding the causes, the fat globules may originate from bone marrow or adipose tissue. Now, let's correlate this point with our anatomy of the bone. All of you, okay, know this fact already. When we take cross section of the bone, the outermost covering is called periosteum. After that, it's a compact type of bone which is called cortex, okay, or cortical bone. Then we'll move on to the medullary cavity, Okay, there is a hollow area at the center of the long bone, medullary cavity. Now, in that medullary cavity, there is bone marrow. Now, bone marrow can be roughly divided into two types: yellow bone marrow and red bone marrow. Now, red bone marrow is a proper bone marrow which is associated with hematopoiesis, and yellow bone marrow is fat. Okay, now you know that what is the origin of that fat. So if that fracture is very bad, okay, worst type of fracture, then those adipose tissue from the medullary cavity can go into the blood circulation. So this is the way. Fat embolism is more common following severe injury with multiple fracture and fracture of major bones. Now see here. So it is more common following severe injury with multiple fractures and fractures of the major bone. The pathogenesis of the syndrome is not clear, not very clear, but it seems likely that two events occur. So what are these? Number one, there is release of free fatty acid by the action of lipase enzyme on the neutral fat, and this leads to toxic vasculitis followed by platelet fibrin thrombosis. So this free fatty acids, they lead to vasculitis or inflammation of the blood vessel. Okay, and after the inflammation, there is formation of platelet fibrin thrombosis in that very small size blood vessel. Now naturally, if they are thrombosed, there will be blockage of the blood circulation. Okay, and another way is those fat droplet or fat globules, they themselves can cause obstruction of the small pulmonary vessels. So one is by causing inflammation, another they themselves block those small pulmonary blood vessels. Let's move on. Now, what are the consequences of this? You know the cause and mechanism, but what's the consequences now? The symptoms are evident a day or so after the injury. So it is classified as the early complications of the fracture. The presenting features are in the form of two, okay, and they are cerebral and pulmonary. In the beginning, I told you these are the two important organs which are involved, lungs and the brain. Now, in the cerebral type, okay, let's talk about this. In the cerebral type, what happens in the brain now? See here. The patients become drowsy, patients become restless and disoriented, and gradually patient develop coma. So this is because of depression of the central nervous system. In the beginning, patient may become restless in hypoxic state, and a bit later patient become drowsy and disoriented, and then ultimately patient develop coma state. This all because of blockage of very small capillary inside the brain. In the pulmonary type, there is tachypnea and tachycardia. Okay, tachypnea is faster breathing, tachycardia is faster heart rate. Now the other common features of fat embolism are a petechial rash. Okay, petechial rash. Please correct the spelling. It should be PE. Okay, petechial rash. These are pinhead size hemorrhage on the surface of the skin. Okay, and that areas are usually the front of the neck, the anterior axillary fold, chest, or even conjunctiva. Conjunctiva is a mucous membrane, so that can also be affected. If fat embolism is untreated, sometimes despite the treatment, even after the treatment, forget about when we do not treat, the patient develops respiratory failure and dies. So this is considered one of the very serious, okay, complication of a major type of fracture. Now, how to diagnose it and then how to treat. So regarding the diagnosis, first of all, very strong suspicion is required. This is called high index of suspicion. High index of suspicion here. Okay. So in which case we suspect this? In a case with multiple major bone fracture. this is suspected, okay, then we can diagnose it early. In addition to the classical clinical features, signs of retinal artery emboli may be present. Now, retinal artery emboli, which leads to striate type of hemorrhage and exudate. Now, there is hemorrhage and exudate inside the retina. The mechanism is same. The retinal blood vessels are also blocked, okay, by the mechanism. Okay, there are two mechanisms. Let us repeat again. The two mechanisms are because of the release of free fatty acid, they can cause a toxic type of vasculitis, and then that toxic type of vasculitis will lead to formation of small thrombi inside the microvasculature. This is one. Second, those small microvasculature are themselves getting blocked by fat globules. These are the two ways. So same thing can happen in the retina also. Sputum and urine may reveal the presence of fat globules. So this is almost confirmatory. Under this scenario, if this type of features are seen, then fat embolism is easy to diagnose. If we take the chest X-ray, and we always take chest X-ray in this situation, because lung is one of the most important organ to be affected. It will show patchy pulmonary infiltration, patchy type of pulmonary infiltration, which is known as snow storm appearance. Now, this is not the same like ARDS. ARDS means uniform type of white-out lung. This is a patchy type of infiltration. Patchy means here and there. So, snow storm appearance. Now, if we take ABG, arterial blood gas, in arterial blood gas, every student know there are few parameters, isn't it? One is pH, another is PO2, or you can say PaO2, okay? PaCO2 or PCO2 and bicarbonate. These are the four major parameters. So out of that, PO2 is very low. It reaches less than 50, and this show the patient may suffer from respiratory failure anytime. Okay, so this indicate impending respiratory failure. Now, what is the treatment of fat embolism now? Here, the most of the treatment is supportive and symptomatic. Supportive and symptomatic. Now, respiratory support. This is important one because this patient is hypoxic. So we need to give oxygen. Okay, oxygen therapy. 100% pure oxygen is necessary. Sometimes patient may need ventilators therapy as well. Mechanical ventilation. Heparinization is done. Now, heparinization, remember the pathophysiology. There is formation of small type of thrombi inside the microvasculature. So heparin therapy is necessary. IV molecular weight dextran, okay, and corticosteroids are tried. Okay, this is a type of colloid actually, this dextran, and corticosteroid is a steroid type of drug, a glucocorticoid. Okay. Now, IV 5% dextrose with 5% alcohol helps in emulsification of fat globules. Now, emulsification means dissolve. It's some sort of dissolvement of the fat. So these are the treatment. But let me tell you again, respiratory support with heparinization is one of the most important step here. So fat embolism syndrome. Now another, let's proceed further. Another type of complication, okay, which is again early type of complication, is deep vein thrombosis and pulmonary embolism. Now let's talk about it. Deep vein thrombosis is a common complication associated with lower limb injury and with spinal injury. Lower limb and spinal injury. Now why in spinal injury? Now, in spinal injury, there is high chance of damage of the spinal cord. After that, there is a chance of weakness of the limb or paralysis. A paralyzed patient cannot move the lower limbs. Without movement or with immobilization of the lower limb, there is a chance that there is a thrombus formation inside the lower limb veins. This is called DVT. Same principle I can, or explanation I can give for lower limb injury also. Because of the immobilization of the lower limb, there is a chance of deep vein thrombus formation. Now, same principles are explained here. See this. The causes of deep vein thrombosis are immobilization following the trauma, okay, which leads to stasis of the venous blood. And we all know if stasis occurs inside the venous blood, there is a high chance of thrombus formation. Never forget Virchow's triad in the formation of thrombus. Now, what is that Virchow's triad? Anyone?
Dilated vein.
Hypercoagulopathy. Hypercoagulopathy.
Turbulent blood flow.
Rupture of blood vessels.
Hypercoagulant blood flow.
Okay.
Turbulent blood flow.
Fine. Now, I already got
Dysfunction of valve in the vein.
good. I already got some of the important answers from the guys. Okay. So listen carefully.
Turbulent flow.
Fine. Let's listen. First, okay, this is called Virchow's triad. So let me write. See, this is the way we revise the important stuff. You know, it doesn't. I don't need to revise this here actually, but just to freshen up your knowledge, I'm doing it here. So Virchow's triad. This Virchow's triad comprises of endothelial injury. Okay, it is called endothelial injury. Number one, endothelial injury means injury of blood vessels. Very easy. Okay. Number two, okay, abnormal blood flow. Abnormal blood flow. You can also call it either turbulence of the blood, okay, blood flow, or stasis of the blood flow. Both are abnormal blood flow, but in the case of thrombosis, stasis of the blood flow is much more important than turbulent blood flow. And third is hypercoagulability. Never forget this, okay? This is one of the favorite questions of the examiner. Coagulability. Now, whenever we come across, thrombosis, we love to ask this. Now, in fracture also, this Virchow's triad is always fulfilled. Then only there is thrombosis of the vein occurs. Let's move on now. DVT proximal to the knee is a common cause of life-threatening complication of pulmonary embolism because they are the big vein and there is a big size thrombus which is attached, and if it gets detached or separated from this vein, it can easily flow towards the heart, towards the right side of the heart, enter into the pulmonary artery, and that is known as pulmonary embolism. This is a life-threatening condition. Now, DVT can be recognized as early as 48 hours after the injury. If embolism occurs, it usually occurs 4 to 5 days after the 4 to 5 days after the injury. Please do not make noise here. Now, what are the consequences of deep vein thrombosis and pulmonary embolism? Okay. Now, this is a good revision for you. So please focus on the slide. A bit of medical knowledge also comes here. Now, regarding the consequences, DVT can be diagnosed early with high index of suspicion. So, first of all, if a patient is having very bad fracture of the lower limb or spinal fracture or injury, and if the patient is not mobilized, okay, for a long time, there is a chance of DVT. This is called high index of suspicion. You just think about it. Then, okay, then think about which population is at risk. Like elderly and the obese patients are already at risk. On top of that, they are having this type of precipitating factors. Regarding the clinical symptoms and sign of DVT, we examine leg swelling and calf tenderness. So swelling of the leg and tenderness of the calf. These are the very important point. Calf tenderness. But you don't squeeze the calf very hard, okay? So why don't you do that? Because you may help the detachment of the thrombus and turn into embolus. You simply very gently, press the calf. If the patient is complaining of pain, or probably you look at the face when you elicit tenderness. If the patient is wincing the face, probably it is tender. Now there is one very important test which you do, that is called Homan sign. Okay, Homan sign. Now this Homan sign is all about, we passively dorsiflex the ankle joint. Passively dorsiflex means ask the patient to relax the ankle, you catch the foot area and dorsiflex the ankle joint. This is called passive dorsiflexion. Now if there is deep vein thrombosis in the calf area, the patient complains of pain, okay, when we dorsiflex the ankle. This is called Homan sign. Now let me repeat again. Homan sign is complaining of pain, okay, and tenderness when we passively dorsiflex the ankle in case of deep vein thrombosis of the calf vein. Now, definitive diagnosis can be made by venography. Venography, okay. Venography is a pushing a dye inside the vein and taking X-ray. Venography, it will clearly tell us where is the obstruction or the thrombus. Now the main danger of deep vein thrombosis is development of pulmonary embolism, so we need to be very aware of the situation, and we should know what are the symptoms and sign of pulmonary embolism if it develops. So the sign and symptom are tachypnea, okay, and dyspnea, that is faster breathing and difficulty in breathing, that usually occurs 4 to 5 days after the accident. Now why 4 to 5 days? A good question to ask, and the answer is it takes time for the formation of thrombus and detachment of that thrombus and turning into embolus. So that much duration is necessary. Now when it goes to the lung, there will be chest pain and hemoptysis. Chest pain and hemoptysis. This is more commonly seen in smaller type of pulmonary embolism. Now before I go into the management, okay, if big type of pulmonary embolism goes inside, okay, what is another term for that big type of pulmonary embolism which can kill the patient? What is the term we use?
Saddle
Saddle,
emboli.
saddle emboli.
Very
Saddle
good.
embolism.
Excellent. Saddle embolus. Excellent. Saddle embolus is a big size thromboembolus which is stuck at the bifurcation of pulmonary artery. So the two branches of pulmonary artery, or pulmonary trunk, I can say, it is stuck right there. So there is no blood flow towards the lung. This can lead to death of the patient very quickly. This is a very serious situation. But fortunately, it is a bit rare. The more common one is small amount of embolus which is going towards some blood vessels of the lung and causing pulmonary infarction there. This is more common. Now, after knowing these things, let's talk about the treatment. Here, elevation of the limb, use of elastic bandage and anticoagulant therapy. These are the important steps of DVT treatment. Elevation of the limb, elastic bandage application and anticoagulation therapy. This anticoagulation again heparin in the beginning followed by warfarin. Now for pulmonary embolism, respiratory support and heparin therapy is to be done because the patient is having probably difficulty to breathe, faster breathing, hypoxia, so respiratory support should be there and heparin therapy is continued. Now what is the cause of this? Okay, now right now we are talking about fracture, the complication of fracture. Remember, the cause of DVT are so many, but let's come to the point here. This is the DVT which is associated with fracture. So we don't forget about the management of fracture as well. So early internal fixation of the fracture should be done. Now, why not the conservative management? Why we are focusing on the internal fixation of the fracture? And the logic behind this is the union or the healing of the fracture is much more quicker in internal fixation. It is known as open reduction and internal fixation. The recovery time is much shorter than the conservative treatment. Now see here, if patient gets better soon, patient start to move sooner, so there is less chance of development of the thrombus. So it's all correlated with one another. Active mobilization of the extremity will cause decreased chance of DVT and decreased chance of pulmonary embolism. Let's move on. After we know the concept of DVT and pulmonary embolism, let's talk about cross syndrome. Okay, cross syndrome. The name itself explains some important points there. Cross means massive crushing of the muscle, okay, along with the fracture. Now, what is happening here? This syndrome or cross syndrome results from massive crushing of the muscle, which is commonly associated with crush injury, and they are sustained during earthquake, air raid, mining injury, or other such big type of accident. Okay, for example, road traffic accident where the limb or the body is rolled over by the vehicle. So these are called crush injury. Now, along with fracture, the muscle is very badly damaged here. A similar effect may follow the application of tourniquet for an excessive period. Now, tourniquet means ligature. Now, sometimes what happens, let me give you some important scenario here. In snake bite, in many parts of the world, okay, snake bite is quite common. And in case of the snake bite, many people will tie that limb so tightly, that when they reach to the hospital, the part is already gangrenous. So this should never be done. Okay, tourniquet is important there, but time and again the tourniquet should be loosened so that there will be good amount of blood flow, and again it should be tighter. So this has to be done, but it is not doesn't mean the putting the tourniquet for a long time and completely forgetting about it. So in that situation also there is damage to the muscle, and a lot of intra muscle content will be released in the blood. This is known as cross syndrome. Now, what is the pathophysiology, okay, or etiopathophysiciology of cross syndrome? Let's talk about it. In this situation, we already talked about crushing of the muscle, but what's the consequences of that? It results in release of myoglobin into the circulation. Myoglobin into the circulation. Now, see here, myoglobin. It is present inside the muscle, in skeletal muscle, which precipitate in renal tubules, okay, in nephron, leading to acute renal tubular necrosis. Now, in internal medicine, when we talk about acute renal failure, okay, we talk about three important types of acute renal failure: pre-renal failure, intrinsic renal failure, and post-renal failure. This is the intrinsic type of renal failure, and intrinsic renal failure is also of two types. One is ischemic, another is nephrotoxic. This is a nephrotoxic type of acute tubular necrosis. In this condition, the myoglobin which are released into the circulation, they are blocking those renal tubule, leading to renal failure. Now, what happens to the patient after this? Let's talk about it. See here. Now, every student can answer this very confidently. This is all about renal failure now. So, acute tubular necrosis produces signs of renal dysfunction like scanty amount of urine, okay, which is known as oliguria. This is oliguria or scanty urine. Apathy, okay, because of the central nervous system involvement. This is called uremic involvement of the CNS, and restlessness as well as delirium. These are some of the important points. It may take 2 to 3 days for these features to appear. Now, regarding the treatment, okay, regarding the treatment, you need to treat for acute renal failure. Treat the patient as if the patient is having ARF, okay. And if the tourniquet was applied, we need to be careful. We need to constantly release it and then again make it tighter, so that those harmful substances which are coming from the damaged muscle into the circulation are decreased. You cannot continuously applying the tourniquet for a long time, and you cannot completely open it also. So gradually it should be released. Okay, it's a type of preventive aspect. Okay, preventive type of therapy. Once it has happened, we need to go for the treatment of ARDS. Now, another important type of complication in case of fracture is injury to the major blood vessels. Now, injury to the major blood vessel, okay, you need to know certain things about anatomy first. In the upper limb, okay, which are those major blood vessels which are quite near to the major bones? In the lower limbs, what are those? Okay, so that's the first thing you need to know, and I'm 100% sure most of the students know this already, isn't it? It's a very easy question. In the upper limb, okay, the major blood vessel is subclavian artery. That subclavian artery will continue as axillary artery. Axillary artery will continue as the brachial artery. Brachial artery will divide into radial and ulnar, and that's how the upper limb is supplied. In the lower limb, okay, in the lower limb, remember the abdominal aorta is divided into two terminal branches. What is the name of the two terminal branch of abdominal aorta? What is the name?
External iliac or internal iliac.
Okay, so you can say common iliac. Yeah, common iliac artery is the answer you need to give first. Then common iliac will again divide into two branches. Okay, that's how you can answer: external iliac and internal iliac. Now, internal iliac is the artery for the pelvic area, so forget about it now. External iliac will continue as femoral artery. Femoral artery will continue as popliteal artery, and popliteal artery, okay, will divide into further branches there, okay, like tibial artery, peroneal artery, and things like that, then supply the lower limb. Okay, this is a bit of anatomy I'm talking about. Now let's come to the topic proper. Okay, focus here. Blood vessels which lie in close proximity to the bone, okay, and they can be easily fractured, they can be easily injured with different type of fracture or dislocation. Among them, the popliteal artery is the most frequently damaged vessel in musculoskeletal injury. Okay, popliteal artery. Popliteal artery is very deep, you know that. That's why popliteal artery is difficult to palpate in clinical examination. Okay, we talked about what are the peripheral pulses that can be palpated. One of the peripheral pulses in the lower limb is popliteal pulse, but it is difficult to palpate because it is very deep, means it is quite near to the bone. That's why there is high chance of damage. Now, this table is telling us the blood vessel which are injured and the trauma which is injuring those blood vessels. Okay, so let's spend a little bit of time here. So please focus. So femoral artery, okay, femoral artery is commonly damaged by fracture of lower third of the femur. Fracture of lower third of the femur. Because of the edge of the fracture, okay, the sharp or pointed edge of the fracture, the femoral artery may be damaged. So here, fracture lower third of the femur. Now, popliteal artery, okay, supracondylar fracture of the femur. Now, this means just above the lower end of the femur there is fracture. Posterior tibial is the blood vessels which is injured by dislocation of the knee and fracture of the tibia because the artery is near to them. Subclavian artery, here, fracture of the clavicle, okay, it is quite near to that. Axillary artery, fracture dislocation of the shoulder joint. And brachial artery, which is very, very important from the exam point of view, is caused by supracondylar fracture of the humerus. So these are the different type of fracture, and these are the blood vessels injured. Let's move on. Please mute yourself. Okay, all of you have to mute yourself. Now, regarding the causes of injury of this major blood vessel, the artery may be damaged by the object which is causing the fracture itself. Okay, one of the example is bullet injury. The bullet injury or the firearm injury can cause the fracture, as well as the same bullet or the firearm may cause the arterial damage as well. So this is one. Another one is by a sharp edge of the bone fragment. This is another common way of damaging the blood vessel, and in supracondylar fracture of the humerus, this is a very common mechanism. We'll talk about this fracture later on, okay, when I move on to the upper limb fracture or lower limb fractures. All these important fracture will be highlighted. The damage to the vessel may vary from just a pressure from outside to a complete torn or rupture of the blood vessel. So it depends, okay, just a pressure from outside to a complete rupture. Now, what happens? What are the consequences to the patient if these blood vessels are damaged? Naturally, there will be obstruction to the blood flow distally. Okay. Now, this obstruction varies. If it is a complete rupture of the blood vessel, if it is completely blocked with no blood flowing distally, then gangrene will occur. Here. But gangrene doesn't occur every time, because usually there is ischemia, okay, not the complete occlusion. Sometimes our lower limb has a lot of collateral circulation. If this collateral circulation is good enough, then the following may result. Now, what are those different type of result here? First of all, if the collateral circulation is excellent around the site of vascular damage, if it is good enough, there will be no adverse effect of the blood vessel injury. So in a lucky type of patient, this can happen. But in other, because of the relative type of ischemia, okay, during the use of the muscle or during exercise, there will be ischemic pain. This is called vascular claudication or intermittent claudication. I'm sure that term is well known to you. Intermittent claudication means whenever a patient is having ischemia on those muscles during the time of exercise, like running, okay, like treadmill running, or any type of vigorous type of walking or something like that, then there will be ischemia, okay, of the muscle, which leads to ischemic pain. This is called intermittent claudication, because after taking rest, the pain will disappear. It all depends on what is the extent of ischemia. Now, some other consequences would be ischemic contracture. Okay. Now, contracture means fibrosis. That muscle which is dead, okay, by the ischemia will ultimately fibrose, and as a result of fibrosis, there is shortening of the muscle. Okay, there is shortening of the muscle. There is pulling up of the fingers. This is like a flexion deformity of the finger, and all of these together is known as Volkmann's ischemic contracture in case of forearm. Now see here, okay, if the collaterals do not provide adequate blood supply to the muscles, now what will happen to the muscle? That muscle will die. This is called ischemic necrosis of the muscle. Very easy concept. Now it is, okay, followed by contracture and fibrosis of the necrotic muscle, which leads to deformity. And this deformity is a flexion type of deformity of the fingers of our hand. And this overall is called Volkmann's ischemic contracture. Very important term, an important question from the exam point of view also. We'll talk about this later as well. The last one and the most lethal of the consequences will be gangrene. If the blood supply is grossly insufficient or abruptly cut off, then gangrene occurs. Okay. Now this gangrene means death of that tissue along with putrefaction or some secondary change. That is called gangrene. Now these are the different type of consequences. Now, how to diagnose? Okay, how to diagnose the injury to the major blood vessel? Now, to answer this question, you need to know, okay, you need to know which pulse we palpate in that region. This is important point. That's why every student should know what are the peripheral pulses you palpate in this situation. So, you tell me now, in the head and neck region, which is the peripheral pulse we palpate?
Carotid.
Carotid pulse.
Carotid.
Very good. Excellent. Every student know that it's carotid artery. Okay. And some of the textbook even mention superficial temporal artery. Superficial temporal artery also. So that's also easy name for you to remember. So carotid and superficial temporal. But these are not related with the fracture. Okay. I'm just asking this question because it's commonly asked in the exam. Now let's come to the point here. In the upper limb, which are those pulses which we palpate? Upper limb.
Brachial pulse and radial pulse.
Brachial and radial.
Brachial, radial.
Very good. So see there, so many students are answering. Excellent. Brachial and radial. Brachial and radial. These are the pulses. So in the lower limb, what are those? Lower limb.
Femoral,
Posterior tibial dorsal.
Excellent. Okay, I already got the answer from the many of you. So femoral, popliteal, dorsalis pedis, and posterior tibial. Femoral, popliteal, dorsalis pedis, and posterior tibial. Excellent. Now let's come to the slide. The pulses which are distal to the injury should be examined in every case of a fracture or dislocation. In every case, even if it is not that bad type of fracture, remember, you still need to palpate it. Just make sure the pulses on both limbs are equal. If one side it is not as strong as the other, we need to ask question, why is this? Probably it is blocked, something else. So this type of question should come. Now, some of the features which suggest a possible vascular injury are listed below. Okay, now pay attention here. These are the signs at the fracture site. So let me underline and explain this. You see that these are the signs at the fracture site. The following signs may be present at the fracture site, like rapidly increasing swelling, massive amount of external bleeding, which occurs in open or compound fracture, and a wound in the normal anatomical path of the vessel, which is very commonly seen in bullet injury. So these are the highly suspicious sign. For example, there's a rapid swelling. That swelling can give pressure to the blood vessel, leading to ischemia. External bleeding means, who knows, the blood vessel itself is ruptured or blood vessel itself is damaged, leading to increase or excessive bleeding. This is common in open or compound fracture. And the same type of cause, like a gunshot or bullet injury or firearm injury, can cause fracture as well as damage of the blood vessel. So this can be there. So we can guess or we can see something at the fracture site. Let's move on. Now another one, sign in the limb which is distal to the fracture. Now this is even more important. Now because that artery is supplying the distal part of the limb. So what are those signs which we examine to make sure that artery is intact or already damaged? So these are 5 P's for you, 5 P's, okay? And I'm sure this knowledge was already shared before. So see here, these 5 P's are pain, pulse, pallor, paresthesia, and paralysis. So let me elaborate on this. This pain is a ischemic type of pain. This is a cramping type of pain. Okay, the muscles which is distal to the fracture site or damage to the blood vessel site is having pain. Second, there is absence of the pulse. This is absent. We are talking about, a complete necrosis of the muscle, so pulse will be absent. But if there is relative ischemia only, pulse is still present, but the strength or volume of the pulse will be low. That's why I am telling you, you should always compare the pulse of both sides, right side as well as left, and then only you know whether this is a normal one or a low volume pulse. Third is pallor. Whenever there is no blood flow to that particular area, that area will be pale, no doubt about it. It's a very easy concept. Another one, okay, first it will be pale, okay, later on it may change color like a blue also, but in the beginning it will be pale. Paresthesia is tingling and numbness type of sensation. Tingling and numbness sensation. So let me write that for you here. Tingling and numbness. This tingling and numbness is because of sensory neuron involvement. Sensory neuron involvement, and paralysis is because of motor neuron involvement. These are also dead, isn't it? Because they also need blood supply. So blood supply is cut off in everything there. Whatever structures are present, all of them would have cut off a blood supply, resulting in these 5 P's. Very, very important point. Okay. Now what else? See here. As a matter of rule, absent peripheral pulses in an injured limb should be considered to be due to vascular damage unless proven otherwise. Absolutely important sentence. So the patient has come to you with injury of the limb. That injury can be done by anything, but the bone is injured or the limb is injured. Palpate the pulse. If pulse is absent or decreased, okay, you have to consider it is because of this injury until proven otherwise. The confirmation of obstruction is done by Doppler study. Okay, Doppler ultrasound it is called, or Doppler study. It can clearly tells us what is the amount of blood flow distal to that particular injured site. Now, whatever knowledge we are discussing till now, especially in the damage of the arteries or major blood vessels, again given here. So take a bit of time, all of you, and pay attention on your screen. See there? So these are 5 P's: pain, pulse, pallor, paresthesia, and paralysis. Okay, pain, ischemic pain; pulse, loss of pulse or absence of the pulse; pallor means white appearance because of no blood supply; paresthesia, okay, tingling and numbness or probably loss of sensation a bit later; and paralysis is failure of the muscle contraction. Now, how we are going to manage or treat? Now, remember, this is absolutely important surgical emergency. We do not have any time to kill here. Okay, we have to try our best to save the function of the limb. So early diagnosis and urgent treatment are of paramount importance here, because the person is going to lose the function of the limb very quickly. So after the diagnosis, correct treatment at the site of first contact has to be done, followed by referral to a center which is equipped with facility to treat vascular injuries is essential. Now we don't send the patient to any type of hospital. Okay, so properly equipped center. Okay, we need to find out that and refer our patients there, where vascular injuries are tackled properly. These days many trauma center can do that. Okay, so there is no difficult thing there. Refer this patient to the trauma center. So this trauma center have excellent surgeon, they can handle this type of situation. In case exploration of the vessel is required, the fracture should be suitably stabilized using internal or external fixation. Internal or external fixation. So what is the meaning there? Let me elaborate this very nicely. Now, how this blood vessel is injured? Okay, let's go back again. One of the important way by which blood vessel is damaged or injured is the sharp edge of the fractured bone itself. So if we do not fix that fracture, okay, then repeatedly that fractured edge is causing damage of the blood vessel. So one of the very important thing right at the site of the injury or first contact is immobilize that area. Use some fixator, use some splint, okay, while you transport the patient. And in the hospital also, we immobilize that area as quickly as possible with internal or external fixator. Then, okay, focus on the vessel. Let's move on. See there, this is a type of flow chart for you. This is a management of a vascular injury to the limb. Okay, we don't explain it completely here, but I'll give a little bit of summarized version to you. So see there. So whenever a patient comes because of this type of problem in the hospital, okay, we palpate the pulse. If there is no pulse, okay, then some basic things we do, like loosen any tight bandages. Who knows, somebody has tied a very tight bandage or tourniquet there, and that is causing more ischemia, so release them. Correct the gross displacement of the fracture under sedation. The displacement is causing pressure over the artery, so correct it. Okay, reduce it. Correct any acute flexion of the nearby joint, because flexion of the joint will again decrease the blood flow distal to that area. So keep those joint under extension with the help of splint. It is called splintage. And watch for the return of pulses within half hour to 1 hour. Okay, but make sure it is not completely ischemic. If there is a complete ischemia, this type of conservative management do not work. But still, if there is a bit of blood flow, then this may help. If pulse doesn't return, okay, refer to the specialized center. Specialized center means again trauma center, the national type of trauma center, where there are very good surgeons and they will take care of it. But if there is no pulse, okay, if there is no pulse, then what will happen now? What will you do? See there, doubtful or poor peripheral circulation, you explore the blood vessel, then you do these different things. Repair it, okay, repair it, use different type of medicine like xylocaine, papaverine, do sympathectomy, and these are the things which we do. So this is the flow chart. You have to revise a bit of more than 1 or 2 times, then it will be very easy. There's no difficult concept at all. Let's move on now. Now, another type of, this is a big topic, okay, I cannot finish it completely today, but probably this injury to the nerve is the last type of complication we'll discuss today. Now, just like blood vessels, these nerves also lie in close proximity to the bone. They also lie very near to the bone, so they may be damaged in case of fracture or even dislocation. Among all of them, the radial nerve is the most frequently damaged nerve in musculoskeletal injury. Now, let me ask you one question. Where is the radial nerve? Where in our body?
In our
Shaft of the hip.
Forearm.
Okay.
Around the shaft of the
Forearm, lateral forearm.
Okay. Now see there. Now, your answer is correct because the question was very vaguely asked. Okay, it was very vaguely asked question. Radial nerve starts from the brachial plexus. It starts from the brachial plexus and then it passes through the upper arm. Okay, then it passes the elbow area and reaches the forearm. Okay, it supply a lot of structure there. So this radial nerve is in very close proximity to the humerus bone. So if there is fracture of the humerus or damage of the humerus bone, radial nerve can be easily damaged. It can be easily damaged. Now see here. Now there is a table. Okay, this table is very important one. So I'll give a little bit of time here. These are the different nerves, okay, which are damaged because of the different type of trauma or fracture. So see here, axillary nerve. Now axillary nerve is also a branch from brachial plexus, axillary nerve. So this axillary nerve is very near, okay, is very near to the surgical neck of the humerus. Now humerus has two types of neck. We'll talk about that in a fracture humerus or dislocation. One is surgical neck, another is anatomical neck. Now, near to the surgical neck, axillary nerve is encircling that area. So any damage, injury of shoulder joint or that area of the humerus can lead to damage of axillary nerve. So one of the common cause is dislocation of the shoulder. Never forget it. Shoulder joint dislocation can lead to damage of the axillary nerve, which results in deltoid muscle paralysis. Now there is another muscle which is supplied by axillary nerve. What is the name of that muscle?
deltoid muscle.
deltoid.
No, deltoid is already written there. One more other than deltoid.
So, teres major.
Is it teres major or teres minor?
Minor, sir. Teres minor.
Minor.
Very good. Teres minor. Okay, that is one extra question which your teacher can ask you. If you answer deltoid, we'll give you almost full marks. Don't worry about that. But you know that muscle name also you have to remember. Teres minor. So deltoid paralysis. Now, if deltoid is paralyzed, what will happen to the shoulder joint? What is the function of deltoid regarding the shoulder movement?
Drooping.
The arm cannot be raised.
Movement of the shoulder.
No,
Cannot raise the hand. It will be adducted.
We
no
cannot.
abduction. No abduction.
Abduction will not occur.
Very
We
good.
cannot move up.
So many answers are coming, okay? But remember one very easy way. The shoulder joint will lose abduction. The abduction movement of the shoulder joint is done by deltoid. So that abduction movement is lost. And deltoid is one of the very, very powerful and important muscle there. Okay. So abduction is an important part of shoulder joint movement, which is lost. Now, radial nerve. Let's come to the radial nerve. This radial nerve is usually damaged. I already talked about it. Fracture shaft of the humerus, because it is very near to it. It is in close proximity to the fracture shaft of the humerus. And radial nerve, okay, supplies so many muscles in our upper limb. In the upper arm, it supplies triceps. Triceps muscle is supplied by radial nerve. And in the forearm, most of the extensor group of muscles are supplied by radial nerve. Now remember, in the in the forearm, the extensor muscles means backside. If you stand in the anatomical position, the back of the elbow and the back of the forearm means extensor group, and almost all of the muscles are supplied by radial nerve. So if radial nerve is damaged, wrist will drop. This is called wrist drop. Okay, wrist drop, never forget it, very important point. Means the extension of the wrist is gone. Median nerve, another important nerve in the upper limb. This median nerve, again a branch of the brachial plexus, is commonly damaged by supracondylar fracture of the humerus. The same fracture which is causing damage of brachial artery is also causing damage of the median nerve. Now let's come to the elbow region. In the elbow, especially in the antecubital fossa of the elbow, there are three important structures which are located side by side. If I take the name of those three structures, what are those? Yes, what are those three important? Yes. These are median nerve, brachial artery, and biceps brachii tendon. So let me repeat again: brachial artery, median nerve, and biceps tendon. These are the three important structures in the antecubital fossa. Okay, so right now we are talking about median nerve injury, and this median nerve is the most important nerve which supply the muscles of the forearm, especially the radial group of muscles, means the muscle which are present on towards the radial bone. These are supplied by median nerve. So if median nerve is damaged, then the effect is called pointing index. So many other things will happen. Okay, we'll talk about that later. We cannot discuss everything in this session. Let's keep it for some other time as well. Regarding the ulnar nerve, this is damaged in fracture medial epicondyle of the humerus, because the ulnar nerve is there. Okay, it is very close to the medial epicondyle of the humerus, and we can even feel the ulnar nerve there actually. Okay, you can roll your finger, okay, near the medial epicondyle of the humerus, and you can easily irritate the nerve, and you can feel some tingling and numbness sensation on the ulnar side of your hand. Even it may reach the little finger. So this is ulnar nerve, and if ulnar nerve is damaged, the person will have claw hand. Okay, it is claw hand. Now sciatic nerve is present in the lower limb. It is the thickest nerve, or you can call it biggest nerve of our body, and it is commonly damaged in posterior dislocation of the hip. Very common way of damaging it. And the sciatic nerve, when it goes distally, it will divide into two terminal branches. I want the name of those two terminal branches of sciatic nerve. What are those?
Common peroneal nerve and tibial nerve.
Tibial or common perineal. Perineal or tibial.
Excellent. All the answers are absolutely correct. Okay, tibial nerve and common peroneal nerve. Very good. Now both of them can be damaged. As a result of this, okay, any type of deformity can be there in the foot area. There may be foot drop. Okay, there may be foot drop due to weakness of dorsiflexors of the foot, or if tibial nerve is damaged, then the opposite type of thing can happen. So all these things occur in sciatic nerve injury. If common peroneal nerve, which is a branch of sciatic nerve, is damaged now, and the damage usually occurs in dislocation of the knee as well as fracture neck of the fibula, because this common peroneal nerve encircle the neck of the fibula and then goes into the anterior compartment, okay, and it supplies there. So it is very commonly damaged in case of fracture neck of the fibula. So The muscles which are supplied by common peroneal nerve are tibialis anterior, okay, tibialis anterior, and peroneus longus as well as peroneus brevis. So if tibialis anterior and those group of muscles are paralyzed, the foot will drop. That means the dorsiflexion of the ankle cannot happen, and this is called foot drop. So these are some of the very important nerve which can be damaged as a result of fracture or dislocation of the related bones. Let's move further. Now we're talking about the injury to the nerves. So what may be the causes of this injury? The causes can be by the agent which is causing the fracture. Example is firearm injury or bullet injury. It can directly lead to fracture because of the high velocity, and it can also lead to damage to the neurovascular structure, whatever is there. Another cause may be direct pressure by the fracture ends at the time of fracture or during manipulation. This is very important one. And one of the good example I want to give here is supracondylar fracture of humerus. That fracture occurs just above the elbow region, okay, just above the elbow joint, I should say. Elbow joint is formed by lower end of the humerus and upper end of the radius and ulna, especially ulna bone. Radius also plays a small role there, okay. So that is, the condyles of the humerus are present there. The supracondylar means just above that. So if that fracture occurs, then the sharp edge of that fracture, the upper bone, you know, the sharp edge of the proximal fracture bone, it can badly damage the neurovascular bundle, brachial artery and the median nerve. So this is the point. Sometimes what happens during manipulation, the nerves or blood vessels can be damaged. Right now we are talking about the nerves, okay, so let's focus on the nerve. So during manipulation, the nerves can be damaged. Manipulation means reduction. For example, the fracture is displaced. Now before you apply plaster of Paris or you treat, you want to reduce the fracture and make the bone align again. During that time, nerves can be damaged. Now another is traction injury at the time of fracture, when the fracture is being manipulated or during skeletal traction. Traction is one of the way to reduce the fracture. Okay, we'll talk about that in management of the fracture class. So traction means constant pulling of the lower end of the fracture site, so that they usually reduce later on. So during that time also nerves can be damaged. Another one is entrapment in callus at the fracture site. Now callus is a immature bone. We all know that. Callus develops at the fracture site. So that callus may entrap some of the nerves. If they are there, then that can also lead to injury to the nerve. It's very important knowledge. Now what happens to those nerves? Remember in the first class, okay, in orthopedics, we talked about some general terms. And during that class, talk about neuropraxia, axonotomesis or neurotomesis. Now what is neuropraxia?
Irreversible damage of the nerve. Damage to the nerve.
Which is only conduction is lost.
Compression to axon of the neuron.
Become compressed.
Very good. Very good. So many students are answering. Okay, I can see their name there. Okay, though many of them are speaking at the same time. Now see there, but you are absolutely right. Neuropraxia is the minor injury to the nerve. It usually occurs because of the compression of the nerve, and the function is completely reversible after few days. It is a reversible condition. Neuropraxia. Axonotomesis. Okay, axonotomesis means there is damage to the axons now. The conduction which is occurring through those axons is damaged, or the myelin sheath which is covering those axons are damaged. So it also will recover, but it takes a longer time. It will also recover, okay, but it will take longer time. One criteria should be fulfilled there for its recovery, that is the outer sheath which is covering the nerve should be intact, isn't it? So remember, any nerve is covered by 3 layers, just like any other structure, like muscles, isn't it? Even the heart, something like that. So those structures are endoneurium, perineurium, and epineurium. Endoneurium, individual nerve fibers are covered. Perineurium, the bundles of nerve fibers are covered. And epineurium, the whole nerve would be covered. So if epineurium is still intact, those axons cannot deviate from that original area. So there is a high chance of growth. The most severe one is neurotomesis. This is a complete division of the nerve, complete division or damage of the nerve. So without surgical intervention, okay, it will not recover. You study like that. It will recover if we treat in time, if the nerve is sutured in time, if surgical intervention is done in time, it may recover. But if it is delayed, okay, and if the surgical recovery is not possible, the nerve cannot regenerate. It's a very important point. So variable degree of motor and sensory loss along the distribution of the nerve will happen. Quite natural. These peripheral nerve, okay, most of these nerves are the motor nerve, sensory nerve, and they are even carrying sympathetic nerve fiber or autonomic nerve fiber, you can say. So all these functions will be lost according to the situation. Now what is the treatment then? It depends upon what type of fracture are there, closed fracture or open fracture. Now see there, the nerve injury associated with the closed fracture is generally neuropraxia or axonotomesis, and nerve recovery is good with conservative treatment. We already talked about. Conservative treatment means plaster of Paris treatment or POP treatment. That is the most commonly done. In case the fracture per se needs open reduction for other region, the nerve should also be explored. Now, another way of fracture management is surgical. That is, we admit the patient in the hospital, we take the patient in the operation theater, we open that fracture area by giving incision. Okay, under direct vision, we do reduction. This is called open reduction. And usually, when we open the fracture site, we can also examine the nerves and the blood vessel. Okay, this is always better. The nerve injury associated with an open fracture is often neurotomesis. Every student can understand, because open fracture means very complicated fracture. The fracture can be seen from outside. It is also known as compound fracture. Some of the pieces of the bone can be seen from outside. The nerves and blood vessels can be severely damaged. Okay, so in these type of cases, surgery has to be done. It should be explored and the nerve should be repaired according to the type of damage. And the fracture is also fixed internally. Now, internal fixation means you open the fracture site, okay, by giving incision. You look what is happening to that fracture area, you reduce it, then you fix it with some instrument, and those may be screws, those may be nail, or those may be plate. So this is one of the best way of treatment of fracture. In today's class, probably in the second half of the class, if I can finish this complication in time, I'll talk about the management. Now let's move on. Another type of complications of the fracture would be injury to the muscles and the tendons. That can also happen when fracture occurs. Now, some degree of damage to muscle and tendon occurs with most of the fracture. We cannot even prevent them. It will happen because of the velocity or character of the force. It may result from the object causing the fracture itself, like a bullet or the axe. Okay, any example you can write here, or from the sharp edge of the fractured bone. The fractured bone itself can cause damage to the muscle, damage to the tendon, damage to the nerve, and damage to the blood vessels. Now, these injuries are overshadowed by more alarming fracture and are detected only late, when the joint distal to the fracture becomes stiff and deformed due to the scarring of the injured muscle. Now, what they are trying to say here is, at the time of bad type of fracture, this muscle injury or the tendon injury will be overshadowed by other type of injury. At that time, the patient cannot move the limb, cannot move that part, isn't it? So we rarely examine the function of the muscle. But later on, when the fracture heals, if there was damage to the muscle, that muscle will also heal. And muscles are permanent type of tissue, skeletal muscle. So once they are damaged, they cannot regenerate again. They will be replaced by fibrous tissue. So that means scar will develop, they will become shortened, and then they will have problem to the joint movement. So these are important points. Rest to the injured muscle and analgesics is enough in cases with partial rupture. Now we are talking about a slight type of treatment here. Okay, that may be enough if it is partially damaged or ruptured. And a complete rupture requires repair. Complete rupture means the muscle is separated, the upper part of the muscle and the lower part of the muscle separated from each other. Definitely we need repair, no doubt about it. And sometimes it may be detected late and reconstruction may be required, especially in the tendon. Tendon can be sutured quite nicely, and it is not a very difficult job. Now, another types of injury which can happen as a complication of fracture is injury to the joints. Now, this is a big topic in itself, and we'll talk about this in orthopedics inside traumatology. These are called subluxation or dislocation of the joint. Now, what is dislocation of the joint? Yes?
Complete displacement
Completely separated from each other.
Displacement of the
Completely separated from each other.
Very good. Excellent. Okay. Complete displacement from each other. Now, joint is always formed by bones. At least two bones, sometimes more than two bones are there. Okay. That is joint. Now, they are in contact with each other, means the alignment of these upper bone and the lower bone are in line with each other. If that alignment is completely disrupted, they are not in line at all, okay, this is called dislocation, completely separated from each other. Subluxation is a partial one, okay, it is a partial one. Maybe a slight part of the joint are still attached with each other. That is subluxation, very common during the severe type of fracture. This combination is becoming more frequent due to high velocity road traffic accident. The important fracture dislocation we are going to talk in orthopedics are shoulder dislocation and hip dislocation. These two are the commonest. Shoulder dislocation and the hip dislocation, very, very common injury. Now, joints are the very important structure for us. Even if there is no fracture, but there is dislocation, and if we do not reduce that dislocation in time, then the functions of that limb is gone. We cannot prevent the function. So early reduction and stabilization of the joint, if it is dislocated, is very, very important point. Similarly, if fracture is very near to the joint, then early open reduction and stabilization of that fracture is very essential to permit the early joint movement. Now, one good example I can give here is fracture neck of the femur. If neck of the femur is fractured, remember the head is supported by the neck. Now that head will be isolated from the main femur bone. Now what is the use of that joint? Until and unless we treat the fracture. That's what I'm talking right now. So treat that fracture quite well. then only the functions of the joint will remain as such. Let's move on. The last part is injury to the viscera. The viscera means inert internal structures. A good example we can give is pelvic bone fracture and rib fracture. They can damage the internal structures like pelvic organ or lung. Pelvic organ and lung, they can be damaged. Now what happens if a rib, okay, if a rib damages our lung, what will happen to the lung? Yes?
Perforation will be occur. Pneumothorax perforation will occur.
Pneumothorax.
Excellent, very good answer. Pneumothorax as well as hemothorax. Okay, these are the two perfect answers. Very good. So pneumothorax and hemothorax occur, and we need to treat these pneumothorax and hemothorax with the help of chest tube. Okay, chest tube has to be kept there. We need to drain this blood from that pleural cavity, as well as air has to be removed. Very good. Now let's move further. Let's enter into some other important complication in this class. Another is osteomyelitis. Now this osteomyelitis itself is a very important chapter or topic in orthopedics. Okay, I will deal with this later on, but right now we are talking about osteomyelitis in relation with the fracture complication. What are the causes of osteomyelitis in fracture? You all know the meaning of osteomyelitis, isn't it? It's an infection of the bone along with bone marrow. That myelo term is for bone marrow. Osteo is for the bone. So infection of the bone along with bone marrow is called osteomyelitis. Now the causes in case of fracture are, okay, it is one of the early complication of fracture. There's no doubt about it, but it may occur late as well. It occurs more commonly in open fracture because of the contamination. In open fracture or compound fracture, there is high chance of contamination of the fracture because the wound is open. Okay, whatever the substance is present on the ground, like a soil, like some other thing, can easily enter into the fracture site, resulting in infection. Another one, the increasing use of operative method in the treatment of fracture is responsible for the rise in the incidence of infection, often years later. This is because of, okay, unsterilized equipment. For example, open reduction and internal fixation has been done. If those instruments were not sterilized properly, there is a high chance of infection in the bone, and that is a very serious problem. Remember one important point: the open reduction treatment of the fracture is very expensive. It is much expensive than the closed reduction treatment. Patient has already spent a lot of money. On top of that, if infection occurs in that area, now what should we do? We need to remove the whole internal fixation device, that plate, those screws, that intramedullary nail, whatever you have kept inside has to be removed. Treat that infection and put it back again. So this will be a big trouble for the patient, big trouble for the family. So we need to be very careful regarding the surgery. Everything has to be aseptic. This is such an important point. And sometimes it can occur years later as well. The infection may be superficial, it may be moderate, or it may be severe. Now superficial means some skin infection. You can give example there, skin infection like cellulitis. Moderate, osteomyelitis, and severe is gas gangrene. They can also happen after the fracture. Gas gangrene, you have studied recently, okay? Gas gangrene, isn't it? Is caused by which organism?
Clostridium perfringens.
Very good. Clostridium perfringens. Clostridium perfringens, also known as Clostridium welsii. Okay, these are the important organisms. Now, regarding the treatment of osteomyelitis, prevention is one of the important aspects. That prevention is proper care of an open fracture or compound fracture. Whenever compound fracture patient comes to us, we need to debride the wound. It is called debridement. That debridement has to be done quickly and effectively, number one. Number two, use antibiotics if you suspect there is contamination, and proper care of the wound. These are three important points by which we can prevent osteomyelitis. But once it has happened, then you need to treat for this. Antibiotics and surgery are the two main ways of treatment of osteomyelitis. Now let's move on. Another very important type of complications of fracture is compartment syndrome. Important from the exam point of view. See here. Now you must be wondering what is this compartment means. Now, these are called compartment. Now, see this. Okay, this is a good schematic diagram which is known as osteophyseal compartment. Now these are the bones here. Let's say this is tibia and this is fibula. Okay, tibia and fibula, or it can also be radius and ulna. Now tibia and fibula, let's talk like that. So this is the interosseous membrane. You all know interosseous membrane is connecting these two bones in the lower limb. Now because of this interosseous membrane and because of the fascia which is covering the muscles, okay, fascia covers the muscle, we all know that, there is the creation of compartment here. See here, there is one compartment. Okay, here is another compartment. These are flexor compartment. Flexor compartment and extensor compartment. There are two types. Now flexor compartment is present on the posterior side of the lower limb, and extensor compartment are present on the anterior side of the lower limb. Exactly opposite of that happens in the upper limb. Okay, we all know that it is because of the difference in the anatomical position. Now see here, the outermost is the skin. Okay, inside the skin there will be subcutaneous tissue, then there will be fascia. This fascia will cover the muscle. So there are lots of muscle in the flexor compartment, and these are the bone. The bones are connected together with interosseous membrane. Now let's come to the point here. If there is a severe fracture occurs of this bone like tibia or even fibula, there will be severe edema formation in this compartment, and there is no extra space here. So this compartment will be tight. As a result of this, there will be a lot of pressure development. This pressure will lead to obstruction of blood flow to the muscles or to the distal part of the limb. This condition is known as compartment syndrome. With this background information, let's move further. See here, the same thing is written here. Okay, compartment syndrome. Now, what are the causes of compartment syndrome? See here, the rise in compartment pressure can be due to any of the following reasons. Okay, 1 minute. Now, this compartment pressure rise can be any of the following reasons. Those are any injury leading to edema of the muscle. That can happen because of serious fracture which can lead to damage of the muscle. Those muscles may be swollen. Fracture hematoma itself. Fracture hematoma means bleeding from the fracture site, and that can act as a space occupying lesion inside that compartment. Another is ischemia to the compartment leading to muscle edema. Now if blood vessels is already damaged from the fracture site, okay, during the initial injury, sometimes blood vessel can be damaged. Now the muscle already suffers from ischemia, and that muscle will be swollen now. That can also further aggravate the situation. These are the common causes. Now the consequence, this is the very important point. The increased pressure within the compartment compromises the circulation. which leading to further muscle ischemia. Now, if that is severe enough, the muscle will die, and after the death of the muscle, it cannot regenerate back. Remember that. So it will be replaced by scar, and the muscle will become short now. So a lot of other complications can happen. So let's move further and talk about what are those. Okay. Now see here. All of you, please focus on this part now. So let me explain this. Here is a trauma. This trauma is causing fracture. Now, because of this trauma, there is muscle ischemia. Now, this muscle ischemia can be caused by the initial injury which has damaged the blood supply of this muscle. That can happen. Okay, so it may lead to histamine release. Okay, there is increased capillary permeability because histamine will dilate the blood vessels. Then there will be intramuscular edema because the leakage of the fluid there. Okay, this intramuscular edema will further increase the pressure in that compartment. After that pressure is elevated, there will be obstruction of the venous return. There is obstruction of the lymphatic flow, and ultimately the arterial occlusion occurs. If it has not occurred before, it will occur now, or if in the beginning it is not complete type of obstruction, because of the rise in pressure, that obstruction will be complete. So this is a type of vicious circle. Once it starts, it will continue until and unless we do some surgical intervention. So this is in compartment syndrome. Now see here, a vicious cycle is thus initiated and continue until the total vascularity of the muscle and the nerve within the compartment is jeopardized. So in the beginning, already the muscle is ischemic because of a bit of damage to the blood circulation. And when this process continue, at last, the arterial occlusion will be even severe. So this is a vicious circle, means it will continue if we do not do anything. That is the meaning of vicious cycle or circle. Okay, once it is initiated, it will go on. Now, what is the result? Okay, what are the results now? See here, this results in ischemic muscle necrosis and nerve damage. The necrotic muscle undergo healing with fibrosis, which leading to contracture. The contracture, okay, is shortening of the muscle. When the muscle gets shorter, what is the function of that muscle? It will let's give you one good example so that you will not forget. In case of lower limb, those toes, the movement of the toes are controlled by the muscles which are present in the leg, because they have long tendon. Those tendons are going and inserted on the toes. Now in the upper limb, the muscles which are present on our forearm, they have a long tendon and they are going and inserted on the finger. So if that muscle is necrosed, it will heal with fibrosis. It will develop contracture. Now think about those fingers. What will happen? They will be bent, especially if these are flexor muscles which are suffering. It will lead to flexor contracture. If extensor muscles, then it will lead to extensor contracture. So this is, very serious type of deformity which may develop. Similarly, nerve damage may result in motor and sensory loss. Okay, whatever nerves are present there, they will be damaged, of course, because they also need blood supply, but blood supply would be lost now. And in extreme cases, even gangrene may occur if the blood circulation is very severe one, or if it is severely obstructed, I should say. So this is about the compartment syndrome. Let's move on. What are the other thing we like to know here? Now, how to make the diagnosis? How to make the diagnosis of compartment syndrome? Then only we can treat, isn't it? First thing is diagnosis. Now, compartment syndrome can be diagnosed early by high index of suspicion. What do you mean by that? High index of suspicion. Yes? Anybody?
Well,
We
sir, if
need
you
to do
want to
proper
diagnose
examination of the.
sir, if you are looking for something else and then we find this on the way, sir.
Okay, good. Yes, Adil, you're saying something? Anybody else? Yes,
Sir,
yes, Sadat, yeah.
we think about that it will happen if there is a fracture, that case will happen, compartment syndrome. So we diagnose it very early, sir.
Okay. Now see there. So your meaning is there, okay? The meaning is there. Now Lukman also is speaking something. Yes, Lukman, you want to say something? Please go on.
Sir, a good physical examination.
Okay. Now see here. Listen. Now you already know which type of fracture has high chance of compartment syndrome. There are, there should be two bones. Okay, there should be two bones present on that particular area, and those anatomical site where two bones are present are our leg and the forearm. In the leg we have tibia and the fibula. In the forearm we have radius and the ulna. Now why I am talking about this? Remember, when there are two bones, they are connected with a membrane that is called interosseous membrane, and that fascia which is covering muscle is everywhere, not only there, in the thigh also it is present, in the upper arm also it is present. So it will divide that area into different compartment. Those are enclosed spaces, and in that area if fracture occur, it has a high chance of development of compartment syndrome. This is called high index of suspicion. If fracture occur there in those sites like tibia fracture, fibula fracture, okay, radius and ulna fracture, we should think about it and check well in the patient. Now what are those symptoms and signs? Excessive pain which is not relieved with the usual dose of analgesic in a patient with an injury. This may be a feature of ischemic pain, and ischemic pain is severe one. It is difficult to control with the help of analgesics. That is one important point. And another one, see there, that what I was talking about, high risk of developing compartment syndrome in this type of fracture, like supracondylar fracture of the humerus, because of the damage of brachial artery. That brachial artery is damaged, so blood circulation cannot happen properly in the forearm. Now those muscles will be swollen, and as a result of this there may be compartment syndrome. Second, forearm bone fracture. Now see there, ulnar fracture, radius fracture, very common. Closed tibial fracture. All this fracture has to be closed. One important point, if it is a compound or open fracture, the pressure cannot be raised there. The pressure cannot become high. The pressure will dissipate outside. No compartment syndrome will ever occur in that situation. So there has to be closed type of fracture. And another one, cross injury to the leg and forearm. The muscles are badly crushed. They become edematous. There is high rise in pressure. So these are. Let's continue. We are talking about compartment syndrome. Now, how to diagnose compartment syndrome? Before the break, I talked about high index of suspicion is necessary. That means at which site the fractures is happening. Accordingly, we can think, yes, this fracture has a high chance of development of compartment syndrome. And those fractures are both bone fracture of the forearm as well as a tibia or fibula fracture of the leg, especially tibia, because it is a big bone. Okay, sometimes when the artery is damaged by the fracture, like supracondylar fracture of the humerus can damage brachial artery, so there is high chance of compartment syndrome development in the forearm. So these are the important points. Now, how to diagnose it early? One of the tests which we can do is called stretch test. Stretch test. What is this? This is the earliest sign of impending compartment syndrome. Impending means developing. Till now, probably it is not that irreversible condition. The ischemic muscle, when stretched, give rise to pain. So it is possible to stretch the affected muscle by passively moving the joint in direction opposite to that of the damaged muscle's action. Now, see this, look at this example, then you easily understand what we are talking here. Passive flexion of the finger produces pain in the flexor compartment of the forearm. Now, let me explain this in an easy way. If you suspect the compartment syndrome is developing in the forearm, in the flexor area of the forearm, then we can do the stretch test. Now, how to do a stretch test of the finger? You extend the finger, okay, not flex. You extend the finger. That means the opposite action of the muscle. The normal actions of the muscles of the flexor group of the forearm is flexion of the finger. I'm not flexing the finger now, I'm extending those finger. Then during that time, there is stretching of the muscle, and that can cause severe pain if they are already ischemic. This is called stretch test. Now, another one, okay, see here, there is hypoesthesia in the distribution of the involved nerve and muscle weakness. Hypoesthesia means loss of sensation. Compartment syndrome can be confirmed by measuring the pressure. If the facility is available, you can measure the pressure, and if the pressure is higher than 40 millimeters of water, it is indicative of compartment syndrome. One very important point, palpate the pulse, okay, palpate the pulse all the time in this type of situation. This is the must. But pulses may remain palpable till very late in impending compartment syndrome and should not provide a false sense of security that all is well. Rather than that, okay, check the capillary refill time. That capillary refill time may be prolonged in case of early impending shock, and rather than the full pulse absent, you know, the pulse may be weaker than the other side. We always compare, isn't it? We always compare between the other side. So if it is weaker than the other, then also compartment syndrome should be suspected. Complete absence of the pulse takes a very high compartment pressure. It may not be present in the early time. Now, what is the treatment? If it has already happened, what is the treatment? Or if it is an impending type of compartment syndrome, how can we prevent it? Let's talk about it. A close watch for an impending compartment syndrome and effective early preventive measures like limb elevation, active finger movement can prevent this serious complication. So elevation of the limb is one of the important points here. Okay, probably to decrease that edema which is contributing in compartment syndrome. And active finger movements can also increase a bit of blood flow there. If it has already happened, then we can go for early surgical decompression. Now, decompression means whatever pressure is elevated, we should release that pressure, and that can be done by fasciotomy. Fasciotomy means cut the fascia, release that pressure. That is fasciotomy. So the deep fascia of that compartment is slit open longitudinally, and that fascia, I already told you, in forearm and in the leg area, and this is very common to happen. So cut the fascia there wherever it is necessary. Another is fibulectomy. The middle third of the fibula bone is excised in order to decompress all compartments of the leg. That can be done. Now you may be wondering, fibula is a bone of our lower limb. So how can we remove fibula? And if it is removed, what will happen to the patient? Okay. So the answer here is the weight bearing of our body is mainly contributed by tibia. Fibula, okay, contributes very less in the weight bearing process. So even if fibula is sacrificed, the person doesn't have major functional problem. That's why fibulectomy can be done. Now, after this, let's move on to the late type of fracture complication. These are late, and these are related with the fracture healing process. These are delayed union, non-union, malunion, and cross union. So let's talk about them. When a fracture takes more than the usual time to unite, it is called delayed union. It is called delayed union. For example, 3 months have already passed, but fracture is not united. Okay, there is no callus formation. Fracture is still moving. This is a delayed union. A large percentage of such fracture eventually unite. Sometimes it takes a bit of long time. Sometimes we do some surgical intervention. Okay, then ultimately fracture will unite. But some of the fracture will not. We'll talk about them, especially the pathological fracture. They have very less chance of healing or unification. In some, the union doesn't progress and they fail to unite. We call this non-union. They fail to unite at all. This is non-union. Delayed union means it ultimately unite, but it takes time, longer time. That's the difference. Conventionally, it is not before 6 months that a fracture can be declared as non-union. So diagnosis of non-union should take time. It should not be done, before 6 months. And there is no callus formation in non-union. In delayed union, callus is formed, but it is taking time. But in non-union, callus is not formed. So these are very important points. In this topic, we are going to talk about all of them. Now here, it is often difficult to say whether the fracture is in delayed union or has gone into non-union. It can be, said properly by the examination and investigation like X-ray. Series of the X-ray has to be taken, and if there is no callus formation, if the fracture site is still mobile after a long period of time, then this is a case of non-union. Okay, non-union. The fracture can still be mobile after a long time. There is no formation of the callus. These are two very, very important points. Now, in the early classes of orthopedics, we talk about pseudoarthrosis. This pseudoarthrosis is a false joint formation there, and this is mainly seen in non-union, fracture, because there is no connection between the upper part and the lower part of the bone, and that non-union may be painless and it is moving. So we call this pseudoarthrosis. It is not a true joint at all. Now the important part, what are the causes? What are the causes of delayed union and non-union? Okay, let's go slowly here. First is causes related to the patient. Causes related to the patient. Now see there, age. It is more common in older age patient than the younger age and the young age. Okay, children's bone can unite very fast, and younger adults bone also can be united well than the older age bone. If the person is having some systemic illness like malignancy or osteomalacia, then the fracture healing takes longer time, or it may not heal at all. So these are some of the important points. Second is causes related to the fracture itself. Now see here, what are those? If there is a distraction at the fracture site. Now what do you mean by that? Muscle pulling the fragment away from each other. Okay, muscle pulling the fragment away from each other. In case of fracture patella, it is quite commonly seen. Now tell me, which muscle is attached to the patella? Which muscle? Okay, wait, probably I have muted yourself. Let me unmute. Yes. Okay, can you answer now? Which fracture?
Quadriceps.
Good.
Quadriceps muscles. Quadriceps muscle.
Very good. Quadriceps. Quadriceps femoris. Excellent. Quadriceps femoris. There are 4 muscles which are together and they form a common tendon. Okay, that tendon is called ligamentum patellae. Okay, that ligament is a misnomer term there actually. Ligamentum patellae it is called, and it is attached to the upper end of the patella, and from the lower end of the patella Okay, it has gone and again attached to the tibial tuberosity. So let's take an example here. If patella is fractured right in the middle, the upper part of the patella will be pulled upwards by the quadriceps femoris muscle. So that is the perfect example. Another is fracture olecranon. Now olecranon is a part of which bone? Olecranon process.
Ulna bone, sir.
Ulna.
Al
It is a part of ulna. Okay, it is a part of ulna. Now, one very important and strong muscle is attached to the olecranon process. Which muscle is that?
Tricep tendon.
Triceps. Very good. It is triceps tendon. Okay, triceps tendon. Now, you can explain it very easily. If olecranon process is fractured from the ulna, then the triceps muscle will pull that fractured fragment upwards. So it is very difficult, okay, to unite the fracture until and unless we go for open reduction and internal fixation, then it will be easy. Gravity is also distracting the fracture site, like fracture shaft of the humerus. Because of the gravity effect, the lower end of the fracture will go distally. If soft tissues are present in between the fracture site, then also they will not allow the fracture to heal, and that can easily occur in fracture shaft of the humerus, fracture shaft of the femur, and fracture medial malleolus, which is called abduction type of fracture. Some of the muscle, some of the other soft tissue may come in between those fractured bone, and fracture is not going to heal. So these are called distraction at the fracture site. Now let's move on. Another is bone loss at the time of fracture. That can happen in compound fracture or open fracture. Now see there, fracture tibia and fracture ulna, if they are open or compound type, a bone pieces may be lost, and of course that bone piece is deficient now. So until and unless we do some sort of bone grafting, it is not going to heal in time. Infection is a very important cause which will delay the fracture union, or it results in non-union. Infection. That's why in compound fracture, whenever the patient comes to the hospital, as soon as possible, we need to clean the wound. We need to debride the wound. Otherwise, infection is inevitable. Damage to blood supply of fracture fragment. The blood supply is vital, okay, for the timely unification of the fracture. If there is ischemia of that fracture site, it is never going to heal. And there are three examples which we commonly like to take. Fracture neck of the femur is one of them. Fracture lower third of the tibia is another one. And scaphoid fracture is the third one. Scaphoid is the is a carpal bone. Every student know that. So if these three bones are fractured, then there is a high chance of ischemia of the fracture site, and it is not going to heal properly. Another cause may be pathological fracture. Already talked about. See here, fracture of the shaft of the femur and fracture of the humerus, if they are fractured as a result of some previous bone disease, then it takes a long time to heal. Good examples of the previous bone disease may be osteoporosis, maybe osteomalacia, maybe metastasis to the bone, maybe bone cyst, isn't it? Any example you can take. So this is a very important question in the exam. What are the causes of delayed and non-union? Now, some other causes would be causes related to the treatment, and that would be inadequate reduction. The reduction is inadequate. It's not enough. You have not done it properly. And this happens commonly in fracture shaft of the long bone, because they are strong bone. There are lots of strong muscles which are surrounding those bone, and those muscles are under spasm, remember that. So technically speaking, this fracture reduction are difficult. You need a lot of power there. You need to relax those muscles. So all those things are there. So sometime there may be inadequate reduction, and because of this there will be delayed union. Another cause would be inadequate immobilization. To heal the fracture, we need proper immobilization of the fracture. That's why we apply that plaster of Paris. That's why we apply those internal fixation, so that fracture will be immobilized. If the patient continuously moving the fracture site, okay, if the patient doesn't take enough rest, if the fracture is not reduced properly, then it will continue to move. It is not going to heal in time. So these are the example for that: fracture shaft of the long bone and fracture neck of the femur again. Another one, distraction during the treatment. During the treatment also, okay, if it is a displace again, then it is not going to heal in time. So these are some of the important point or causes of delayed and non-union. Now let's move further. Let's talk about some other aspect. What are the types? Okay, what are the types of non-union? The two types or two main types of non-union are atrophic type of non-union and hypertrophic type of non-union. Now see there, the atrophic type of non-union, where there is minimal or no attempt at callus formation. Let me underline and explain this. Atrophic, where there is minimal or no attempt at callus formation. And hypertrophic, where though the callus is present, it does not breeze the fracture site. Means probably it is forming a little bit outside the fracture area. It is not breezing the upper piece of the fragment and lower piece of the fragment. So even if it is bigger in size, what's the use of that, isn't it, if it is not uniting the fracture? Now look at the picture here. Okay, see this? Look at this. This is upper part of the bone. This is lower upper fragment and lower fragment, you can say. I cannot see any callus here. Where is the callus? No callus there. So this is atrophic. Second is hypertrophic. Okay, see that this callus is present, but it is moving away from the main fracture site. It is expanding outside. So it is not present at the main area. So this is hypertrophic type of non-union. Both of them can be mobile very freely. If we move, that fracture site will move even after many months. This is the important point of non-union. What are the sites where non-union occurs commonly? They are neck of the femur or fracture neck of the femur, scaphoid fracture, fracture lower third of the tibia, lower third of the ulna, and lateral condyle of the humerus. So these are very important examples which we love to ask in the exam. And there are many multiple reasons for this, Now in neck of the femur, the important point for the non-union of the fracture is lack of blood supply. The head of the femur usually gets its blood supply from the neck, or through the neck, I can say. So when neck is fractured, those blood vessels are also damaged. So head will become ischemic and fracture is not going to heal in time. Scaphoid, same thing, again ischemia. Lower third of the tibia, again ischemia. These are the three very important examples. Now lower third of the ulna and lateral condyle of the humerus, they displace. It is very difficult to reduce them for a longer time. Okay, let's move on. Now, what are the consequences of delayed and non-union? So what happens to the patient? Now, delayed and non-union can result in persistent pain in the fracture site, deformity, or abnormal mobility at the fracture site. Now this pain is more common in the delayed union than in the non-union. In non-union, usually there is no pain. In delayed union and non-union, there is abnormal mobility. Now again, that mobility is more common in non-union than in delayed union. Okay, so this is important point. A fracture in delayed union, if stressed, can lead to refracture because it is not strong at all. Okay? Some factors are there which doesn't allow the fracture to heal in time. So if we again, okay, give more stress to the fracture site, it leads to refracture. That's why patient should take enough rest. Okay, they should not keep on moving that fracture site before the proper unification. But that doesn't mean they should take complete rest. Some type of movement is necessary. What I'm saying here, do not apply a lot of weight bearing from that joint or from that fracture site. Now let's talk about how to diagnose it. Many of the points we already talked about. Okay, so let's combine all of these together. So diagnosis is always made on the basis of clinical examination and investigation. History is a part of that. So delayed union is a diagnosis in relation to time. Definitely, the fracture may not show any abnormal sign clinically, but X-ray may fail to show the bony union. So X-ray is a very important investigation which we need to do to make sure whether it is delayed union or non-union. What are those important clinical findings which suggest delayed union and non-union? Okay, a bit of revision for you now. Persistent pain, more common in delayed union. Pain on stressing the fracture, again more common in delayed union. Mobility, more common of course in non-union because there is no callus, or even if the callus is formed, it is not in the proper fracture site. And increasing deformity at the fracture site in non-union because the bone are not in continuity with each other. Okay, they are displaced, so deformity will be persistent. So clinical feature with investigation will give you the diagnosis. The following are some of the radiological features which suggestive of this complication. Now, delayed union, the fracture line is visible. There may be inadequate callus bridging the fracture site. That's why it is called delayed union. It is not healed in time, so I can still see the fracture line. And more importantly, some amount of callus is there. That's why the fracture has not healed in time. It is healing slowly. That's why delayed union. But non-union, the fracture line is clearly visible, no doubt about it. Okay, there is very little bridging callus or no callus at all. Sometimes more callus is there, but it is not at the fracture site. The fracture end may be rounded, smooth and sclerotic, and the medullary cavity may be obliterated. Now these are not a good sign in the X-ray. These signs suggest us that this fracture is a non-union fracture. So let me repeat again. The fracture end may be rounded, may be smooth and sclerotic. Sclerotic means it is a bit more dense there. It looks more whitish than the normal. That is the meaning. And medullary cavity, which is present at the center of the bone, may be obliterated or it may be closed. This is not a good sign for the fracture. It is a sign of non-union. Now, sometimes it is very difficult to be sure about union of a fracture where internal fixation has been used. Now, let me tell you what is internal fixation. Probably, okay, some of the students are still confused with this. And this is another special topic for us, which we will discuss after we complete the complication. Internal fixation means this is the surgical type of treatment of a fracture. We open the fracture site and we apply some instrument there, okay, like screws, like plate, like nail or rod, and we fix the fracture. This is called internal fixation. Now, when internal fixation is used, okay, all the sign which we just discussed may not be that very visible. So a series of X-ray has to be taken, okay, and you have to see very carefully at that internal fixation device. Then only you can find out whether it is a non-union or not. But it is rather difficult than in conventional treatment of the fracture. Excessive rotation may be the only abnormal mobility in a case with intramedullary rod in situ. This is one of the good example of internal fixation. See this intramedullary rod. It is commonly used in fracture shaft of the femur. So they have treated that fracture shaft of the femur with this device. Now this patient has developed non-union of the fracture. So there is still excessive rotation which may be observed. This can happen in non-union. Now some other views can be taken, like an oblique view, to diagnose if this in time. Okay, in the beginning we always do AP view and lateral view, but if you are in doubt, you have to go for some other view, like oblique view done under fluoroscopy. This is important one. And then you can go with some other advanced type of X-ray, like stress X-ray or weight bearing X-ray or even 3D CT scan to diagnose this delayed and non-union properly. These are only necessary if the diagnosis is a bit difficult and challenging with the ordinary X-ray and with your clinical examination. But nevertheless, the facilities are there. Now, finally, okay, how we handle this type of complication? What should we do if a patient develops delayed union or non-union of the fracture? Most fracture in delayed union, they unite on continuing the conservative treatment. Now, what do you mean by conservative treatment, guys? Though I have not taken this class, but still you may know this. Yes. What is conservative
POP
treatment?
cast, sir.
POP.
Exactly. POP or plaster of Paris. This is the most important type of conservative treatment. Very good. Okay. Or sometimes we don't do anything regarding the fracture, especially in the flat bone fracture. You don't need to do anything. Just ask the patient to take rest and take analgesic if they develop pain. That type of treatment is called conservative treatment. Sometimes you keep on pulling the bone, okay, with the help of traction. That is also a type of conservative therapy. That's the point. So what do we do in delayed union? Most fractures in delayed union, they unite on continuing the conservative treatment, but they are taking longer time. Sometimes this may not occur and the fracture may need surgical intervention, that is open reduction and internal fixation. Okay. In the short form, we call it ORIF, very commonly used term in orthopedics. Okay, ORIF, open reduction and internal fixation. Now, bone graft with or without internal fixation may be required, especially in non-union. Bone graft with or without internal fixation may be required. Treatment of non-union depends upon the site of non-union and the disability caused by it. And some of the important, examples see here: bone reduction, internal fixation, and bone grafting. This is important in non-union of multiple fractures, and the grafts in this situation are taken from iliac crest. And the internal fixation we use is usually the plate with the screws. Plate with the screws with some of the bony graft which we take from the iliac crest. It will help the fracture to heal. It will still take a bit of longer time, but ultimately we hope it will heal. Now, one small question for you: whenever the term iliac crest comes, another procedure we do very commonly in the hospital. That's a type of investigation. What is that we do in the iliac crest? Yes?
Bone marrow biopsy.
Bone marrow biopsy.
Bone marrow biopsy.
Very good.
Bone marrow biopsy.
Very good. Excellent. Okay. Some of the students are even saying lumbar puncture, and they are also right. So let me explain this for you. The answer here is bone marrow aspiration or bone marrow biopsy. It is done from the iliac crest, especially from the posterior superior iliac crest, okay, on the back side. So you can easily say this is iliac crest. Another one, you palpate that upper border of the iliac crest and you draw a transverse line, and that transverse line is a guideline for lumbar puncture as well. Okay, that is a guideline because that transverse line will pass from L4 and L5 vertebra, means the intervertebral space between those two vertebra. So we almost know that is the area for us to have lumbar puncture. So these are the very important question which will be immediately asked to the student if this type of terms comes. Let's move on. Okay. Now, one of the treatment in these conditions is excision of the fragment. Now, in which situation we need to excise the fragment now? See here. Sometimes achieving union is difficult and time consuming. So we cannot wait, forever. It is taking a long time. Okay. So we have to go for this type of therapy. Now, this can only be done where excision of the fragment will not cause any loss of the function. A small part of the bone may be sacrificed here. An excision may or may not need to be combined with replacement with an artificial mold or prosthesis. Okay. It may need prosthesis or it may not need prosthesis. We cannot say right now. It depends on the site of the fracture which we are going to treat. Now, for example, see here, then everything will be clear. The lower end of the ulna can be excised for non-union of the fracture of the distal end of the ulna without much loss. Okay. The lower of the end of the ulna can be excised, a small part, without much functional loss. That is an important point. Why? Why we are saying this? Let's go back to our anatomy again. In the forearm, there are two bones, radius and ulna. The upper end of the ulna is an important bone near the elbow region, but lower end of the radius is the important bone near the wrist joint. That's why we can easily sacrifice the lower end of the ulna, okay, without having much functional problem. See there. So this is the way we are balancing the things up. If that bone is not having important function there, and if it is necessary to excise a very small piece which will help in the fracture healing, we can go for that. Another one, non-union of fracture of the neck of femur in an elderly person, which is very common, especially in old people who are more than a 60-year-old or 65-year-old. The non-union of the fractured neck of the femur is quite common. What we do now? The head of the femur can be replaced by a prosthesis. This is known as replacement arthroplasty. Now, you may be wondering why we do that. Because the head is still there. So why we remove that head and replace it with artificial device? The answer is, I already told you, if you remember, in fractured neck of the femur, there is high chance of ischemia development in the head. Now that head is already dead most probably. Okay, this is called avascular necrosis of the head of the femur. Avascular necrosis of the head of the femur. Now what's the use of that dead bone and why we keep it there, isn't it? It will cause a lot of problem if we do that. So let's remove it and replace the whole joint with artificial device. This is called arthroplasty, a replacement arthroplasty. You can also call it hip arthroplasty, very commonly done in the treatment of fracture neck of the femur. Okay, So let's move on. Now, some other treatment of delayed and non-union would be no treatment is done. For example, if patient doesn't want any treatment, remember you cannot do treatment on your own. You should need a consent from the patient side. The patient says, no problem, doctor, I can live with this, no treatment. See here, some non-union, they do not give rise to any symptom and hence require no treatment. Non-union of the fracture scaphoid is the example, because it doesn't contribute much, okay, regarding the function. Another one is Ilizarov method. Ilizarov method is Ilizarov, the Russian surgeon, okay, orthopedic surgeon. So he has done a lot of things in orthopedics. So we will talk about this later on during the fracture management. Okay, this is Ilizarov technique or method. So what he did, Professor Ilizarov from the former USSR designed a special external fixation apparatus for the treatment of non-union. That is called Ilizarov method. It is a type of external fixation device with a lot of pin which are put on the bone, and fracture will heal in time, though it takes a bit of. Now, the important one from the exam point of view are delayed union and the non-union. That's why we talk that extensively. Now, after doing those, let's move on to the malunion. Now, what do you mean by this? Mal means improper. The fracture has united or healed, but in an improper way or not in a proper position. So when a fracture doesn't unite in a proper position or united in a improper way, that is called malunion. A slight degree of malunion occurs in a large proportion of the fracture, but okay, if it is malunited in a bit of more abnormal way, then it can lead to persistent disability, and this disability is of clinical significance. Now, what do you mean by that disability? For example, the fracture is persistently displaced. It is angular type of unification or healing. This leads to disability. So malunion is also one of the important complications. The causes of malunion would be improper treatment. You have not properly reduced the fracture and then just treated the fracture like that. That leads to malunion. Now look at the example here. The common site, fracture at the ends of the bone always unite, but they often malunite. And good examples are supracondylar fracture of the humerus and Colles fracture. Now these, why they always unite? There is a reason here. Why fracture of the bones or end of the bone, I should say, always unite, or there is a high chance of unification than shaft of the fracture? You can answer this.
Because it grows from the ends. If epiphyseal plates are there.
Okay. Any other answer? Yes. Now listen here.
So the ends are easily
because of osteocytes.
Okay. Now listen. It depends on which type of bones are present near the ends of the bone. These are cancellous bone. At the shaft, it is cortical bone. Cancellous bone always heals better than the cortical bone. That is the main reason. So what is the point here? Even if you do not reduce the end of the fracture perfectly, the fracture will unite, but it is often malunite. Means still some sort of deformity may still be there. And supracondylar fracture of the humerus and Colles fracture is the good example. Colles fracture means distal end of the radius fracture. Okay? Radius, the distal end is fracture, which is called Colles fracture. What are the consequences of malunion now? Let's move on. Malunion results in deformity, shortening of the limb, and limitation of the movement. The most important one is deformity here. Regarding the treatment of malunion, each case is treated on its own merit. Means we cannot generalize the different type of treatment together. A slight degree of malunion may not require any treatment. It depends on the patient also. If they are fine with that type of malunion, we don't need any treatment. If patient complain, doctor, it doesn't look good, then we need to do something. That is the point. Now see there, the following treatment possibilities can be considered. One is, okay, because of the deformity itself, we need to go for the correction. Because of the shortening of the limb, we need to go for the correction. And because of the functional limitation, we need to go for the correction. Functional limitation means the joint movement may be limited now as a result of that malunion. So we need to go for the correction. Now, what are those type of therapy now? So some of the method for treating malunion are osteoclasis or refracturing the bone. Now this is a very interesting type of principle. So here, refracturing the bone, osteoclasis we say. So what we do there, it is used for correction of mild to moderate angular deformity in case of children. Under general anesthesia, the fracture is recreated again. The angulation is corrected and the limb is immobilized in plaster of Paris. So they refracture that part because it has not united properly. We are not satisfied with the healing of the fracture. So we do the refracture and then retreat again with a proper reduction. This is called osteoclasis. Another, redoing the fracture surgically. This is the most commonly performed operation for malunion, and in this case, the fracture site is exposed surgically, the malunion is corrected, and the fracture site is fixed internally with a suitable implant, okay, like screws, like plate, okay, like rod, something like that. So this is surgical retreatment, you can say, because we are not satisfied with the original one. Another is bone graft. The bone graft is also performed in addition, in most cases, malunion of the long bone. So if malunion is there and during the treatment a piece of a bit of gap is left, then you can graft certain piece of bone, mainly from the iliac crest, that will really help the unification in a right way. These are the important points. Let's move on now. Okay. Now, another type of therapy is called osteotomy. It's called corrective osteotomy. Now, osteotomy, okay, is cutting a bone. Osteotomy. So the deformity is corrected by osteotomy at a site which is away from the fracture, as the healing may be quicker at this new site, like supramalleolar corrective osteotomy for malunion of distal third of the tibial fracture. Now let me make it simple for you. So what the surgeons are doing here, okay, they are correcting the deformity in that fracture area by not doing anything there, but rather than that, they will cut a bone a little bit away from the original fracture site, and they will do treatment there, so that the alignment is again maintained. This is called corrective osteotomy, and it is mainly done for malunion of distal third tibial fracture. Another type of therapy which can be done is excision of the protruding bone. Now malunion is a type of deformity, so whatever bone has protruded outside, then we excise it. A good example is in fracture of the clavicle, a bone spike protruding under the skin may be shaved off. Okay. We may shave that part of the bone. Shaving means excision. Same may be required in a spiky malunion of a fracture of the shaft of the tibia. So excision of that protruding piece of the fracture site, that is the meaning. Let's move on. And another, which I've already told you, is no treatment. If the patient doesn't want any treatment, if patient says, no doctor, it's all right for me, no treatment is required. Okay. Now, another important complication of the fracture is shortening of the limb. Now, shortening of the limb. Now, what may be the causes for this? It's a common complication of fracture resulting from the following causes. One is malunion, improper union. For example, the fracture has united with an overlap or marked angulation, which occurs in most long bone fracture. If it is angulated, then definitely the limb is going to short. Crossing, actual bone loss may be there. Some pieces of the bone has been lost from the wound site. Okay, this is very commonly occur in gunshot or firearm injury. And growth defect, if injury occurs to the growth plate, that is epiphyseal plate of the cartilage, which is present near the end of the bone, then it may also result in shortening. This occurs mainly in children. So these are some of the important causes of shortening of the limb. Then what treatment we need to do? Okay, can we treat this type of conditions or not? Definitely we can. So what are the treatment options? A little shortening in upper limb, okay, goes unnoticed. Hence, no treatment is required. This is important point. For shortening in lower limb, treatment depends upon the amount of shortening we have. Like, if shortening is less than 2 centimeter, it is not much noticeable either by the patient or by other people. So, it can be compensated by a shoe raise. Okay, now see there. Let me underline this important point. It can be compensated by a shoe raise. So, slight, thick sole shoe is given to the patient, and that will compensate for the problem. Another is, if shortening is more than 2 centimeter now, okay, and if it is noticeable, what we are going to do? In elderly patient, it may be compensated for by raising the shoe on the affected side again. But in younger patient, correction of angulation or overlap, which is the cause of shortening, is corrected by operative method. Okay, that is called limb length equalization procedure. Limb length equalization procedure. It is required to correct shortening in an old, healed and remodeled fracture. So that fracture has not properly healed, probably malunited. That's why it is causing shortening. So we need to do this type of corrective surgery. Let's move on. Another important, okay, type of complication which we are going to talk now and which is very important from the exam point of view is a vascular necrosis of the bone. And this is one of the important complications of the fracture. Now, the name itself suggests a vascular necrosis is the loss of blood supply to that particular area. Now, let's talk about this. The common site for avascular necrosis are head of the femur. And this head of the femur is necrosed usually in fracture neck of the femur and posterior dislocation of the hip. Now see there, one is fracture, another is dislocation. In both conditions, the head of the femur will lose its blood supply. As a result of this, it will die. That is called avascular necrosis. Now we don't keep this dead, okay, head there. It will cause a lot of problem. Number one, persistent pain may be there. Number two, over a period of time, it can lead to osteoarthritis, and that osteoarthritis is a painful condition. So to avoid this situation, we need to replace the head of the femur by, okay, artificial device there, okay, which is called prosthesis. Another important, fracture which cause avascular necrosis is proximal pole of the scaphoid fracture. Okay, I mean this proximal pole of scaphoid commonly gets avascular necrosis. That's what I want to say here. And the cause is fracture of the scaphoid, which has gone through the waist of the scaphoid bone. Waist means middle part. If that middle part of the scaphoid is fractured, the proximal pole of the scaphoid will lose blood supply. As a result of that, it will die. Again, avascular necrosis. The third important example is body of the talus. The vascular necrosis occur in the body of the talus in this fracture. That is, fracture through the neck of the talus. Again, it will lose blood supply. That's why it will happen. One more, which is given commonly in the book, is fracture lower third of the tibia. That fracture can also have a ischemic complication and can develop a vascular necrosis. But rather than a vascular necrosis, non-union is very common in that site. Okay, it is more of non-union. But you can add that example here. Now, what are the consequences of avascular necrosis? What happens? Avascular necrosis causes a deformation of the bone. Definitely, no doubt about it. And another important one I already talked about is secondary osteoarthritis a few years later. And osteoarthritis is a degenerative disease of the joint, especially the synovial joint. And this osteoarthritis will cause painful limitation of joint movement. This is a serious complication. So to avoid this, okay, a person have already developed avascular necrosis of that particular part, then we sacrifice it, we remove it and probably replace it with some other prosthesis. A perfect example I can give you is fracture neck of the femur, where head of the femur is dead. We remove that head of the femur. This is called arthroplasty. Now, how to diagnose this? See here. Diagnosis of avascular necrosis, okay, is suspected first. We should have a high index of suspicion, just like we discussed this before, like in a compartment syndrome discussion. A high index of suspicion is necessary, and that suspicion we get if those respective bones are fractured, like a neck of the femur fracture, scaphoid fracture, isn't it? Talus fracture. So avascular necrosis can easily happen during those types. Pain and stiffness appear rather late, and radiological changes as given below appear earlier. Okay, let's talk about those radiological changes. But before we talk, just have a look here. All of you, please focus on the X-ray. Let me use the pointer. See here. You can clearly see. Okay, this is femur bone. This is femur. This is head of the femur right here. This is called acetabulum. Acetabulum is a part of hip bone. Okay, you can still see the fracture line here. The fracture line. So 2 screws have been used here. These are the screws. So this is an example of internal fixation, which is very commonly done in fractured neck of the femur. I already told you, because the blood supply of the head is going from the neck, okay, like this. So those blood vessels must be damaged here, resulting in avascular necrosis of the head. Now look here, it looks much more sclerotic. It looks more denser than the other part of the bone. This is one of the very important feature of avascular necrosis. Now we are going to talk about that. Just focus on the slide. Number 1 is sclerosis of the necrotic area, which I have just talked about. And what may be the reason for this? See here, the avascular bone is unable to share the disused osteoporosis as occurs in the surrounding normal bone. Hence, it stands out densely on the X-ray. So the diffuse osteoporosis cannot happen in this area because it has lost the blood supply, as easy as that. Second one, deformity of the bone occurs. The rounded shape of the head is no more. It will get collapse because it is no more stronger. Very easy explanation. The head is very rounded structure, but it is collapsed now. That rounded structure is lost. Okay. Third one, osteoarthritis features may be seen. Now the features of osteoarthritis, if you remember, we also discussed this in the beginning of the orthopedic discussion. That is, decrease in joint space is one, and presence of osteophyte is another one. Then there will be osteosclerotic development in the margin of the joint. These all are important features. So some of those important features we can see in this area also. So all of this can be seen by X-ray. But if you do bone scan, now bone scan, so what is bone scan? Anyone can give me the appropriate answer? What do you mean by bone scan, guys? Yes?
PET scan.
Okay, PET scan. Yes. Any other answer?
The skin is attached by bones.
Now see there, this bone scan means we use some radioisotope material. Okay, radioisotope material we attach. Okay, then we inject that. Now that radioisotope material will not go or cannot go in the ischemic area because it has to go there through the blood supply. But blood supply is cut off here. It is already gone. That's why that area is avascularly necrosed, right? So we cannot see any collection of that material, that radioisotope material in that area. So that area look cold on the bone scan. That is the meaning. It is much more sensitive than the X-ray because the changes occurs much earlier. But some of the disadvantages of this, okay, this I should say limitation rather than disadvantage. It is not available everywhere because it is an advanced type of investigation. Now, what treatment you like to do in avascular necrosis? Now, see there, avascular necrosis may be prevented by early energetic reduction of susceptible fracture and dislocation. It has to be done very quickly after the fracture has occurred. If we delay the reduction of the fracture, then the area already got ischemic and it will die. So proper treatment in time has to be done. Another one, okay, once it has already occurred, the following treatment options are remaining. It has already been dead, you know. So what options we have now? Let's talk about it. Delay the weight bearing on the necrotic bone until it is revascularized, thereby preventing its collapse. That dead bone is a weak bone. If the patient is weight bearing quite early, then that bone will collapse and nothing can be done. Even if it is revascularized by some treatment, then it cannot come back to the original shape. It takes anywhere from 6 to 8 months for the bone to revascularize after proper treatment. Long time. So do not do weight bearing before that. What are those revascularization procedures then by which we can again make that joint functional or that bone functional? These are using the vascularized bone graft. Vascularized bone graft. Okay, now for one example, there is a vascularized bone pedicle graft from greater trochanter of the femur in avascular femoral head necrosis, which commonly occurs in fractured neck of the femur. So what they are doing here, to revive this femoral head which has lost its blood supply, they are borrowing vascularized bony pedicle from greater trochanter of the femur so that it will get its blood supply again. This is the one. Now, what are the other type of therapy or the treatment? Excision of the avascular segment of the bone, okay, is one other treatment because it is already happened. So we cannot do anything. The treatment is already late. We have not done treatment in time. So just remove that part by excision, and it is done in fracture of the scaphoid commonly. Another type of therapy or treatment would be excision followed by replacement. Excision followed by replacement. Now see there, in fracture of the neck of the femur, the avascular head can be replaced by a prosthesis, very commonly done surgery. And another is a total joint replacement or arthrodesis. Total joint replacement or arthrodesis, which may be necessary. A total joint replacement means there are two parts of the joint, the upper part and the lower part. The thing which we just discussed is only replacement of the upper part. Okay, so lower part, sorry. In case of hip joint, the upper part is acetabulum and the lower part is head of the femur. We can discuss like that. In this case, we only replace the head of the femur. So it is not a complete or total joint replacement. But if the arthritis has already developed in acetabulum, then we have to I am muting all of you now. That guy is not listening. So the total joint replacement or arthrodesis can be done, okay, if the both end of the joint are having problem. If osteoarthritis has already developed in acetabulum and if the head of the femur is already dead, we need to go for total joint replacement therapy. This is called complete or total arthroplasty. And arthrodesis is one of the options. Now, okay, let me unmute you once again and ask you this simple question. What is arthrodesis? Who can answer?
Permanent fusion of joint.
Permanent fusion of the joint.
Permanent fusion of the joints.
Permanent fusion of the joint.
Very good. Excellent. All of the students are answering it correctly. This is permanent fusion of the joint because the thing which is forming that joint is already non-functional. So we fuse the joint in an appropriate direction so that still some of the functions are saved. This is called arthrodesis. Let's move on. Another important complication which can occur quite late in case of fracture is stiffness of the joint or joint stiffness. It's a common complication of fracture treatment, and the common joint which are stiff are shoulder joint, elbow joint, and knee joint. They are quite common. And the causes are, see here, intra-articular and peri-articular adhesion which forms around the joint secondary to immobilization. Now, after fracture, we don't ask the patient to move it quite early. So some of the stiffness will definitely occur. There's no doubt about it. Later on, we correct them by proper physiotherapy or exercise. But here, I'm talking about more stiffer than those normal. Okay, and in which type of joint, fracture they occur? In intra-articular fracture, there is more chance of adhesion and more chance of stiffness. Another cause is contracture of the muscle. Contracture of the muscle. You see here, if contracture occurs around a joint because of prolonged immobilization, then after the fracture is healed, still the patient will not have proper function because of the contracture, means stiffening or contraction of the muscles for a long time. Again, the treatment is physiotherapy. Another reason would be tethering of the muscle at the fracture site. That means entrapment of the muscle at the fracture site. So we need to treat it surgically. So these are some of the important causes which will hamper the activity of the joint. Now, what is the treatment then? See there, some of the treatment are quite simple, okay, and some are a little bit complicated, or surgical therapy. Now let's start from the easier one. The treatment of the stiffness of joint is by heat therapy. Heat therapy. You see here. Okay, that is done by hot fomentation, means application of heat on that local area which is having spasm. Wax bath and diathermy, these all are different examples of heat therapy, and they really help. And another one is exercise. Exercise is one of the most important part of fracture treatment, though we do not give importance to this in the beginning, but after the healing or union of the fracture, physiotherapy or exercise play a big role, because there has to be, or there will be, some of stiffness of the joint. To bring that joint completely back into the normal functioning ability, physiotherapy plays a big role. Sometimes we need to manipulate this under general anesthesia. Okay, so GA is also necessary sometimes. Please mute yourself. Now, sometimes, okay, wait. Okay, let's move on. Some surgical interventions can be done in the following circumstances. Simple type of therapy may not help. We need to go for surgical intervention. So what are those? To excise intra-articular adhesion, preferably through arthroscopically. Now, arthroscope are a special instrument like an endoscope, which will be inserted inside the joint cavity, and we do certain surgery with the help of this. So very easy principle now. If there are adhesions formed inside the joint, we may remove them arthroscopically. To excise an extra-articular bone block, can do that. To lengthen the contracted muscle, we have to go for surgery. And for the joint replacement, of course, we have to go for surgery. So these are the different interventions which we can do in a case of stiffness of the joint. Another important complication of fracture is reflex sympathetic dystrophy, also known as Sudeck's dystrophy. Another term is also there, which is called causalgia. Now, this is a relatively common type of complication after fracture, and this means there's a group of vague, painful conditions which are observed not only after the fracture but as a sequelae of trauma as well. And the trauma is sometimes relatively minor in comparison to the problems which is seen in the patient. So what we say is the symptoms and signs are out of proportion to the trauma. Trauma looks minor, but sign and symptom would be much more serious for the patient. Regarding the pathophysiology, we really do not know what is the reason behind it. Sometimes it may be because of abnormality in pain perception by the central nervous system. Sometimes maybe because of imbalance between sympathetic and parasympathetic nervous system. Sometimes maybe dysfunction because of sympathetic nervous system. Different reasons have been given, but exact mechanism is not properly known. The consequences in the patients are they have pain, hyperesthesia, means increased sensation, okay, rather a lot of discomfort in the periphery or distal to the fracture site or injury site, tenderness and swelling in the finger. It is very common in that area. The skin becomes red, shiny and warm in the early stage, and later on the skin becomes progressively atrophied, and the muscles and nails also become atrophied. So I can connect a little bit with sympathetic dysfunction here. Joint deformity and stiffness occur because of this. As a result of this, when we take the X-ray, there will be spotty type of rarefaction. Spotty rarefaction means there is patchy type of resorption in the bone. So this is an important point here. We are talking about reflex sympathetic dystrophy or Sudeck's dystrophy. The treatment is rather difficult here. This is something like chronic pain syndrome in the limbs, and many of the time the trauma looks not that serious, but the pain is persistent and for a long time. Means the proportion of pain is much more severe than the amount of trauma, and the exact mechanism is relatively unknown how this sympathetic dystrophy occur. In different book it is mentioned that the pain perception from our brain is altered, and some even mention there is dysfunction of the sympathetic nervous system, or the balance between sympathetic and parasympathetic nervous system is disturbed. Okay, so many different mechanisms are highlighted here. So regarding the treatment of this patient, proper counseling is really necessary. Physiotherapy plays a main role or principal modality of the treatment. Further trauma in the form of an operation or forceful mobilization is very detrimental, means we do not go for it. In some cases, beta blocker and sympathetic block may aid in the recovery, or it may show good response because the involvement of sympathetic nervous system, so probably they help. And the ultimate therapy is actually prolonged physiotherapy and prolonged management of the pain. This is called chronic pain management. Now, can you tell me which drug we give for chronic pain management? Anyone?
NSAID.
Yes, one is NSAID. Any other drug apart from that?
Ketorolac.
Say it again.
Ketorolac, analgesic.
Okay, they are analgesic only, ketorolac. Now listen here. I am giving you clue. Remember about trigeminal neuralgia or herpes zoster type of infection, where there also become chronically pain. Patient may complain pain for a long time. So which drug we give? These are anti-epileptic drug like carbamazepine, valproate, isn't it? Gabapentin, all those drugs can be given. Amitriptyline, they are the drug which can be used in the management of chronic pain syndrome, and reflex sympathetic dystrophy is one of the example for that. So this is one small extra knowledge for you. Let's move on. Now we have reached to the final part of the last important complication of fracture, which is myositis ossificans. And I'm going to discuss that in this class. After that, I'll move on to the general principles of management of fracture. This myositis ossificans is also known as post-traumatic ossification. This is a very interesting mechanism. This is ossification of the hematoma which is collected around a joint. Now hematoma, okay, collects all the time as a result of fracture. In compound fracture, it is lost outside, so the hematoma doesn't collect there, but in case of closed fracture, it is there. So what that hematoma is doing here? It is resulting in the formation of a mass of bone which restrict the joint movement often completely, and this condition is known as myositis ossificans. Another synonym is post-traumatic ossification. What may be the cause for this? Let's talk about it. It occurs in case with severe injury to a joint, especially when the capsule and the periosteum of the joint have been stripped from the bone by violent displacement of the fragment. This is very common around the elbow joint. So if there is severe injury around the elbow joint area, which results in stripping of the periosteum and detachment of the joint capsule, that fracture hematoma can later on result in formation of the myositis ossificans. It is common in children because periosteum is loosely attached to the bone in case of children, and that's why it can easily strip off. And massage following the trauma is a factor which is known to aggravate myositis. So we should not do massaging around that fractured area, okay, especially in elbow injury. Now, what are the consequences of myositis ossificans? So please pay attention here now. See this. This is the elbow joint. This is the lower end of the humerus. This is ulna, and this is radius bone. The radius, ulna, and lower end of the humerus. This is elbow joint. If severe injury or fracture occurs around the elbow joint, leading to hematoma, there is a chance of myositis ossificans. Now you can clearly see there is ossification, okay, which is not only confined to the bone. It has gone out of the bone, for example, till here and here. This is called myositis ossificans. Let's come back to the slide now. The bone formation leads to stiffness of the joint. In this case, it leads to stiffness of the joint due to thickening of the capsule or due to the bone blocking movement by this newly formed bone. In extreme case, okay, the bone movement or the joint movement is impossible. This is known as extra-articular ankylosis. Now, ankylosis means fusion of the joint. There are two types of ankylosis: bony ankylosis and fibrous ankylosis. Okay, bony and fibrous. Now, in this condition, actually, the joint is not having much problem. The problem is around the joint or surrounding the joint. That area, okay, is developing ossification, which is hampering the movement of the joint. That's why it is known as extra-articular ankylosis. So radiologically or with X-ray, we can see these type of things. We can identify it with the help of X-ray. It is clearly seen here. What about the treatment of myositis ossificans? Massage following injury is strictly prohibited. Okay? We don't advise for that. In the early active stage of myositis, the limbs should be rested and NSAIDs are given. NSAID, non-steroidal anti-inflammatory drug, the same example which you were telling me before, the management of the pain, you are right. Acute pain management can be done by NSAID and opioid, but chronic pain management should be done by some other type of drugs. In late stage, okay, it is possible to regain movement by physiotherapy, and in some cases, we have to go for surgical excision of the bone mass which has formed there, because that bone mass is hampering the elbow movement or that joint movement. So this is myositis ossificans.